Tittan COVID-19 project. We are today in the headquarters of the Galician Health Knowledge Agency in Santiago de Compostela, and here in this room they are also our colleagues from Basque Country, from BioF and Osakidetza, and also from the DHI from Scotland. Today, this conference will last until 2 o'clock, and the Tittan project started in 2016. It was a network for exchanging good practices related with healthy and active aging. And in 2020, we had an extension of this project, of 1 year extension of this project, to exchange knowledge about COVID-19 good practices. The conference of today, it is divided into 5 sessions plus a debate. One each region: Galicia, Scotland, Basque Country, Saxony, and also Lombardy in Italy. And you can make questions through the platform slido.com. Here on the corner of your screen, you can see a QR code with a number of code 3926512, and you can make questions and also to participate in online and live polls. And now we will start with the institutional welcome from Antonio Fernandez Campa, that he is the Managing Director of the Galician Health Knowledge Agency, ACIS, and also Carmen Duran Barrondo, that he is the General Directorate of Public Health. Antonio, Carmen, tiene palabra.
Pues, buenos días.
Good morning. Not very long ago, in December of 2019, we came to know about the first case of this new virus in China, which we thought was a faraway thing, especially when we were seeing the first cases that it was extended. The local authorities had to take certain measures. But in January of 2020, we started to know the first cases of travelers who were coming back to Europe, and they were infected by this virus. 2 years later, the data say that 535 million people have been infected in more than 260 countries of the world. So it's been something that has been quite difficult for us to understand. We didn't know that we were going to face this. It's been a huge change for the world. These situations made us think of the memories that we had about the so-called Spanish flu and the situations like lockdown and news. I remember when the news said something that the children were going to go out to the street the following day. We couldn't have imagined that this kind of news were going to be there. Obviously, this has been a huge challenge for society, but it's been an even larger challenge for the healthcare systems that have had to face this pandemic. This has led to a situation in which the healthcare professionals have been working very hard in very complicated situations in which scientific evidence was very scarce and very variable. It changed every day. And so we had to adapt constantly. Even in such a complicated scenario, the healthcare professionals have been proposing actions that have tried to improve the quality of healthcare, and this has been good for the citizens. It is surprising how in practically 3 months from not having any reference of this virus, and suddenly all the hospitals had a very good diagnostic capacity. If we think about the progress made by the scientific community and the industry by developing the vaccines, I think this is a historical milestone, and we're practically not aware of how important this is. I don't think we're aware of how much progress this has been to be able to have efficient vaccines in such a short period of time. As I say, this is a scientific milestone, and it's going to be something that society will never forget. So in this framework in which the professionals have been working and all these initiatives have been carried out, actions such as this one of Tittan COVID, whose aim is to bring knowledge and to add value to all the best practices developed around the globe. It's of the essence to be able to know and share all these different actions that have been developed. And as we said at the beginning, the aim has been to help to mitigate the effects of the pandemic. Throughout this program, throughout the different sessions that have been developed under it, we've had the opportunity to get to know different sets of good practices in the regions that are involved in this program, with special thanks to all the people who have taken part in these sessions and that have made these actions known, because sharing is essential for knowledge to flow amongst us. So this is the last session here in Santiago de Compostela. Santiago de Compostela in Galicia is the end of the way of St. James, centuries old way that pilgrims from all over Europe have traveled precisely to share their knowledge and to share their know-how, and also to be able to contribute altogether to build this Europe as we know it today, which is all about sharing experiences and knowledge. So all I can do now is to welcome you all from Galicia to this session and to thank you once again, to thank you all for your participation. And as the pilgrims say that travel the way of St. James, may you have a good way. Thank you. Thank you, Antonio. We'll start with the first session then for today. That is for Galicia. We have the first presentation by Carmen Duran Barrondo, Secretary of the Healthcare Service of Galicia here in Santiago de Compostela, as well as the Director General for Healthcare. This is she's since 2020 been the General Director of Public Health of the Galician Health Ministry. She's going to speak of the management of the pandemic of the SARS-CoV-2 virus in Galicia. Thank you very much, Carmen. You have the floor. So good morning, ladies and gentlemen. First of all, I'd like to thank you all for inviting me. Thank you, Antonio, for inviting me to take part in this forum. And thank you very much to all the people who are now connected online. Although we can't see your faces, we can feel your warmth. My message to you today is with great humbleness. What are the practices that we consider have been innovative, that have added value to this complicated management of the pandemic? As the manager of ACIS just mentioned, this has been a situation that we have never faced before in our country, and obviously in yours neither. In order to set the context, we have the next slide, please. Thank you. I think it's important to share the features of our region, Galicia, the Autonomous Community of Galicia. These are features that may be strengths and somehow also weaknesses that could hinder or give an advantage in managing the pandemic. Galicia is it's an autonomous community of Spain in the northwest, with approximately 2.7 million inhabitants. We have a series of features. As we said, we have a great geographical dispersion. We have low populational density, especially present in the rural areas. Besides, our region has an aging population, a lot of elderly people. And this is also manifest in the fact that out of 2.7 million inhabitants, we have more than 400 social health centers to house people with disabilities or elderly people. These two characteristics we have highlighted in red. These could be two difficulties in managing cases and also COVID contacts, but also to be able to organize the vaccination campaign. Besides, although we do have a relatively strong public health system in Galicia, we were lacking a public health network across the region. We did not have the capillarity that is needed for public health, which also added difficulty in terms of managing what do we do with the outbreaks, or how to contain them, or how did we manage the cases and contacts. What was in our favor? In our favor, we have a highly qualified healthcare system. The people are very experienced and they have a lot of technical and scientific knowledge. And so this gave us some security, despite the fact that there was no scientific evidence. At least these people had a very sound criteria in terms of decisions to be made on experts' opinion. This was one of our strengths. The other strength that I would like to highlight, that I will insist upon during these next 30 minutes, is the great progress that we have in Galicia regarding innovation and digitalization of all that which we could call healthcare, including public health. This was a great advantage, as you will soon see, when it came to the vaccination scheme, as well as to help and care patients at home. With this snapshot in our head, in this context, I think that we can start with this diagram that I prepared to be a sort of a script to see what are the items that we're going to insist upon during my presentation. All that I'm going to tell you has to do with the surveillance and follow-up of the COVID pandemic. First of all, the best practices in the management of cases and contacts. We're going to speak about what we did with the diagnostic tests for COVID. We're also going to speak about what we did by integrating information systems, and also I would like to make some comments on the importance of having a clinical committee of experts that have assisted us at all times when it came to decision making. Some of the decisions were popular, others were not. Besides, we have to be very serious when we speak about this second block. That's the social health centers and elderly people's homes. This was a very vulnerable group of people. We all know that that's where the pandemic had most incidents in terms of morbidity and mortality. I think Galicia had good practices, innovative practices, mostly based on medicalizing these homes, and also integrated homes. And last but not least, I think that we had very good practices regarding healthcare provision, where technology in caring for patients at their own homes was a strong point, and a platform was generated that is included in the electronic health records to manage contacts and cases. So with this schedule and the previous snapshot of our strong weak points, first thing that we came across in Galicia when we faced the pandemic was the need to increase the number of diagnostic tests. When we had the reagents, because there was a time that we could not do so because we did not have enough reagents for this. Imagine the context that we lived in, where there were outbreaks throughout the entire community, and that we had to have early detection of all the cases to be able to isolate them at home and to stop the contagion. This required an intensification of all the diagnostic tests and using PCRs. With the system that we had in Galicia, with our 14 major hospitals, it was not enough, and it was not practical nor efficient. So we designed certain practices that I'm going to share with you now. One of the most novel ones was to call to use what we called the COVID auto COVID. These would be nursing devices to take samples from the patients to perform the PCRs, but they didn't have to get out of the car. They would drive. It was a drive-in system. As you can see, there were signs to direct people where to take the samples for the PCRs in this drive-in auto COVID. We started with 14 points at each hospital, so the users would not have to get out of the car. The nurses would take the samples, and then the results were given to the patients. We started at the hospitals, but then we also organized these same drive-in COVID testing places in downtown settings when we had lots of outbreaks in the cities, and we had also mobile testing centers with trucks that would travel all around the geography to make sure that the drive-in COVID was not only in the larger urban areas, but also to expand it to all the rural populations that are so disseminated. And thus we reached the furthermost areas. To get an appointment in these drive-in, we managed different systems. First, by having the general practitioner to send to the patients, or with the SMS messages, and also the self-appointment by the patients themselves that didn't have to go to the GP. If they had symptoms, they could request an appointment by an app, using an app of the Galician healthcare service. And we also had free points where the citizens themselves could go voluntarily to the drive-in COVID without the need to request any kind of appointment, just because they might have had some symptoms or because they wanted to make sure if any of their family members was infected. All of this, although they were mobile points for the drive-in COVID, all the information systems were integrated. We did not wish to lose the opportunity of using the technological progress. We were using no paper. All the communication was performed in real time with the clinical microbiology laboratory, and the patients got their results if it was negative via SMS, and if they were positive, they were told, they were called either by the GP or by the follow-up contact centers, a series of agents hired by the healthcare system. We started with PCRs, but as soon as we had antigen tests available, we also did the drive-in COVID with antigen tests, providing the results immediately. And as I said, we increased all these points for the drive-in COVID according to the needs. Here we have an example. This is what you see in the picture is a truck. There was one in each one of the 14 healthcare districts. On the inside, it was more or less like a healthcare center with a nursing department and all the necessary devices. And the goal was to have it at a site that was easy to reach. No prior appointment was necessary. So any individual that would like to have a diagnostic test could go there freely without requiring an appointment. I think this picture is of Christmas in the year 2021, when we expanded the screening to all the population who would like to make sure that they were not infected, especially around Christmas time, where we knew that more infections could happen. Despite all of this, the time came when the drive-in COVID was not enough, because we needed to have a proper systematic weekly screenings at all the old people's homes that we had in Galicia. Not only for the elderly, but also for the workers. I speak about between 50 to 60,000 people that we needed to screen weekly. The time came also when we saw that certain areas or certain age groups, especially younger people, had accumulated incidence that was very high, and we decided that we had to screen practically the entire population that was between the ages of 18 and 25. So we started with a pooling that was done with nasopharyngeal screening, but also with saliva pooling. What you see on the slide is, so to speak, to industrialize the diagnostic tests. The picture that you have above is the laboratory in Vigo that was the one that selected to centralize all the saliva pooling in Vigo. That is perfectly automated from the reception of the samples to the final results. This was very, very efficient. And the lower picture is when the samples from all the elderly people's homes arrived. some 7,000 PCRs that arrived daily, and in 24 hours we had the results. With this, we managed to improve, especially as we said, because we had weekly screenings at the elderly people's homes and also spot screening in certain cities. But that was not enough either. The time came when we needed to have, we had solved the diagnostic test issue partly through pooling, but we needed more points where the patients could go to conduct a test, for which we used the collaboration of the pharmacies. All the pharmacies were involved. They were not necessarily a part of the healthcare system in Galicia. So we had the collaboration of all the pharmacies. Most of the pharmacies in Galicia collaborated in this scheme. They had the test tubes to collect the saliva that they would dispense to the citizens, and the citizens would take the test tube home. They would collect the first early morning saliva. They would then take it to the pharmacy, and we had a transport system that collected all these samples daily and took them to the central laboratory in Vigo to be processed. And so we managed to screen continuously the entire population. We also, well, the diagnostic tests have been an essential tool, not only for us, but also for the entire community, of the healthcare professionals. We had to supplement this with some sort of a predictive test that could tell us what was going to happen. And so very early on, we started analyzing sewage water. We started with a project in Coruña, and then this was extended to other health care areas. It's a supplementary tool. It's not decisive, but it helps us, together with the mathematical models, to predict what could happen in the next few weeks. Very early on, perhaps before it was fashionable, quote unquote, to use sequenciation, we started sequencing. The public health system invested a lot in sequencing and automating the screening, also at the central laboratory that, as I mentioned, is located in Vigo. And so we started sequencing, especially when some outbreak had very special characteristics. It was a very strong outbreak with a fast growth. So we started sequencing, as I said, and it's not by chance that perhaps we were one of the first regions to declare the cases of the Alpha variant or the Delta variant in Vigo. This was Galicia. And it was thanks to this early sequencing scheme. We have the sequencing that also allowed us to perform activities to contain the cases, to contain the pandemic in a very surgical manner in certain neighborhoods, in certain areas where we saw that there was a different variant, or that we were going to see that this might happen. Once having concluded all the diagnostic tests and having solved the problem of these diagnostic tests, I think it's also important to highlight, with all the information, the use of digitalization and innovation regarding the records and information systems. As I said, perhaps the second challenge that we had for the healthcare system is that we needed an IT platform to collect all the information, not only in clinical microbiology, but also of the cases, the contacts. And so we designed this platform that you see, which is Vicia. This platform enabled us to perform an epidemiological surveillance that was very efficient. What Vicia did, that's at the core, this platform was fed by all the information that came from microbiology, all the information that came from the preventive health care systems that were basically controlling the cases at the hospitals, and also all the information from the old people's homes of the territorial centers that would be our capillarity network throughout the region, and all the information that the headquarters for contact follow-up. These were agents hired by the healthcare system. as well as all the healthcare provision. So this platform collected diagnostic tests, information about cases, information about contacts. We knew in which area most of the cases and contacts were located, and all the healthcare provision surrounding COVID, including the number of patients in hospital, in normal wards, or in intensive care units. With all this information from the healthcare system, we drafted reports. I'll show you some examples soon that enabled us to make decisions as to what restrictions we would need to implement, not only in Galicia, but also in every one of the cities and towns that make up Galicia, and also share this information with the Spanish ministry so they would have a snapshot of what was happening in our region. And this is one of the examples of this system that I tell you about, the centralized information. We had a daily report of the cumulative incidents, 3, 7, and 14 days for each municipality, for each of the populational centers that we have in Galicia. This also allowed us to know the distribution by age groups for each one of the contacts. I've brought you the health care areas. We have 7 areas in Galicia, and in the whole of Galicia, although this is broken down in all the municipalities that make up our region. We could also draft this map of what was happening. This is a very simple map that we had on our website, where you can see perfectly well the distribution of the cases. See how the colors could tell us the cumulative incidence. This was completed with the thermal maps, in which we were capable not only of knowing where most cases were concentrated in each city, but also to see down to the street level. So the time came when we could fine-tune this, and thanks to these maps and to the thermal maps, we could design very surgical actions. We were also looking to all the hospital admissions, and we were also concerned to have a daily snapshot of all the cases as in old people's homes, the users, and also the workers, to be able to have exhaustive surveillance of what was happening and to implement the necessary measures. With all this information that I'm mentioning, plus the study of the outbreaks, plus the study of the variants, plus the monitoring of the care capacity in our region, plus the monitoring of the effectiveness of vaccination schemes when we started vaccinating in Galicia, using predictive mathematical models, we could draft very lengthy reports with the cumulative incidence, the percentage of positive cases, the ratio of rates, the number of orphan cases, and with all this information, we could make decisions at the heart of the clinical committee, and that's the picture you have below. It's just 4 of the 35 professionals. There were 35 professionals in healthcare that made up this experts committee, the clinical committee, whose leader was the president of the regional government. In order for you to have an idea, every week we had at least one meeting of the clinical committee where the president was present, and also the head of the health department, the Galician Minister of Health, the Director General for Healthcare, and the 35 professionals in the team. At the heart of this clinical committee, all the decisions were made that the people of Galicia know, such as closing night leisure and also restrictions in the hotel and catering industry, or to decide whether a certain municipality had to be limited in terms of partial lockdowns or a perimeter closure, so people could not access or leave the city. All the people who are here are nodding because they have suffered from all these limitations, all these constraints. So the decisions were made at the heart of this scientific committee with the president of the regional government at the head of the committee. And so the pressures that we felt from the healthcare system were much less because the top responsible person was the one to ratify the decisions of the clinical committee. Before going into this part, I would like to say how we communicated to the people who were cases or controls. If we reached so far, we'd have to think that all these initiatives, all these procedures that I'm telling you about, we believe have been successful. Galicia has been throughout the pandemic one of the regions in Spain with the lowest cumulative incidences at 7 and 14 days. And perhaps we've suffered less also the pressure on the healthcare system. We've never had to use any kind of extra hospital device to house our patients, nor have we used some priority criteria. In other words, we've been able to handle the cases and contacts without much problem. And although I don't like to mention the case, the ministry published some statistics of avoidable mortality, and Galicia has always had the best results, considering that despite having had a lot of deaths, and we have to respect these people and their families that have suffered so much from the pandemic. As I said, in this relative success to manage the pandemic, we've also been capable of establishing communication channels that are very direct, both with the cases and the contacts, as well as the overall population. We have brought together telephone contacts to communicate the individual that they were positive, and there was a daily follow-up to see whether these people had symptoms, and also to make sure whether they were under quarantine or isolated. After this telephone communication, we had the SMS communication. You have to realize that we have reached more than 10,000 cases daily when the Omicron variant appeared. And we also had to use SMS messaging because it was very complicated to call 10,000 people per day plus 50,000 contacts. It was very complicated. Another very important tool, in my opinion, at the clinical level, is the one that you have at the bottom of the slide. This is the clinical record of Galicia, which is unique for hospital care, and it has been developed for many years in our region. So what we did there was to bring forward the working lists so each doctor, each nurse could know at all times which of their patients had been positive in COVID, which of their patients were direct contacts of positive cases, and so they could have a proper follow-up, a very close follow-up that was completed with this electronic platform for home care, which we called ELEA, that's enabled to provide positive patients with access to the platform, this electronic platform. There were also given other assistance, and so they could write down their temperature daily or measure their oxygen saturation. And the doctors and nurses, every day when they open their computer at their office, at a glance, it's very straightforward. They could know if there was any parameter, if there was any thing that was out of normal, and to get in touch with the patient. Those that have no color, that are all gray, that means everything is normal. Those that have yellow or orange are on the limit of normality, and the doctor and nurse could start taking action and call the patient. And those with red is because a parameter was totally out of what was recommendable, and so they would directly contact the patient and call the emergency system, which is the 061, and if necessary, the patient was taken to the relevant hospital. And this is very straightforward, and we think that to have the patient monitored at home made Galicia be the one with the lowest, one of the regions with the lowest percentages of hospital admissions. In fact, the number of cases that we had would correspond to a certain percentage of hospital admissions, and we had much less. And it was probably due to this constant home monitoring scheme. To carry on with the healthcare, not only we digitized and used technology to monitor patients, but we advanced with our contingency plans. When Galicia had no case, ACIS, all the surgical actions were stopped with the aim to be proper organized. We had contingency plans according to the level of hospital admissions and intensive care units. How could we expand the wards available and also to reach other areas? There was some healthcare area that had a very limited space and needed more wards. What we did was to think of Galicia as one single hospital. So if the hospital area of Pontevedra had any shortage of intensive care wards, then we could transfer the patients to the health area of Vigo, because Vigo has many more wards available than Pontevedra. And also at the time when the patient was admitted to the emergency ward, if they were going to worsen their condition, we could transfer them elsewhere. So we had these very strong contingency plans, but we didn't need to really use them outside of the hospital environment. And regarding old people's homes, as I said, we were all aware that this was our Achilles' heel. More than 400 centers, an elderly population, and where most morbidity and mortality was happening. So we undertook several actions. Anytime there was an important outbreak at a home, it was medicalized. We had an intervention on behalf of the Galician Healthcare Service, and they started to depend directly from the healthcare system. And the home was provided with doctors, nurses, to try to contain the pandemic and provide care to these people with symptoms. We also had some homes that were only for positive cases, in such a way that we could transfer all the positive cases to a home and consider all the other elderly people's homes as free of cases, as free of COVID. And finally, I think this has been one of the paradigms that has helped us make a change in the model of our old people's homes. We had people up to 150 people living in the same home with common rooms, common dining rooms, and so forth. And COVID helped us change this into modules, so the people would be grouped in groups of 30 and not hundreds. And so the outbreaks could be easier to control. In terms of logistics, I wanted to share with you also two best practices that were very useful to have an efficient management of all our resources. One was centralized procurement. So no health area would purchase on their own. We had a centralized procurement logistics platform, and everything was purchased directly by the health department. And we distributed everything with our logistics to all the health areas according to their needs, but of all kinds of materials needed. I think this was one of the features that made us suffer less from the scarcity of materials. We never needed more breathers than those that we had purchased, and we had purchased a lot. We didn't need more beds than we had already available. This enabled us not to have too many problems during the pandemic. And all I have is a couple of pictures to show you. I wanted to make a special reference to the vaccination scheme. I think that Galicia must be very proud throughout the entire vaccination campaign that took place. We are proud of our professionals that made it possible, and also the population who were massively attending the vaccination schemes. As you know, we had a logistics scheme whereby the vaccines were provided in large venues and also at the old people's homes that I mentioned. The COVID vaccines were also sent to the healthcare centers where we vaccinated people above the age of 80. And then we established in large venues, such as those that you see on the slide, where the vaccines were delivered from early morning with a traceability system. And by the end of the morning, all the vaccines that were left over were collected so as not to waste one single dose. With this, we managed to guarantee, apart from the electronic system, the SMS appointment, and we also sped up the vaccination using QR codes. So when the individual arrived to be vaccinated with the machine, the QR code was read and all the data were immediately available, and there was no time wasted looking for the clinical record. With this direct inverse logistic system, large venues, a capillary distribution of the vaccination and different methods, we achieved for Galicia to be, as I said, one of the regions that was leader in Spain in vaccination. Here you have some figures. In most age groups, Galicia is a leader in Spain, especially compared to the average. And if we go to children, we can see this huge difference. See that we're speaking about 79%, almost 80% of children vaccinated between the ages of 5 and 12, with at least the first dose, as compared to the average in Spain, which is 55%. And with the full schedule, it's 70% compared to 46% of the Spanish average. So we have more people vaccinated. And apart from the awareness that Galicians have had with vaccination, I think our logistics system has been very important in this case. Now, last but not least, with this full transparency, we have a website that you can access because we still have it ongoing today, where all the vaccination data are uploaded, and we also have all the positive cases, those that were in hospital, those who were in intensive care, and also the number of people who passed away. There were other indicators, but I just bring you one example. This, as I said before, was one of our means of communicating to the population. We communicated through the website and providing also weekly press conferences to explain to the population what was happening and what measures we had adopted and the reasons for them. And I'd like to take this opportunity to tell you that public health, the public health system learned the lesson. We believe that out of all any crisis is an opportunity, and this has shown us that we need, not only in Galicia or Spain, we need in the world to have a strong healthcare system, a stronger healthcare system. We can no longer continue to be the invisible friend. We need to continue growing. We need to continue growing, and we have to also engage in self-criticism. We need to have professionals that are properly trained, who are capable of confronting new health crises. And this pandemic is not the last health crisis that we're going to be facing in our country or the world. We need to continue improving the digitalization of health, public health. We have, at least in my directorate, we still have a long way to go, and we need to promote transparency and communication. We need to improve the strategies for epidemiological surveillance. We cannot have epidemiological surveillance that is reactive. It has to be proactive. Otherwise, it's useless to have strong surveillance systems. And of course, we need to continue to network throughout Galicia for public health. And I'd like to mention 3 initiatives that we have already started for public health. We have created the Galician School for Public Health, which we intend to be the one to train our professionals. We are creating the training pathways. We think that our professionals must be perfectly capable. We have already tendered the Galician Observatory for Public Health. There's going to be a window open to the world so all the world can see what we are doing. How many people are obese in Galicia? We need to know this at a click. We need to have a map where we know where we have more tuberculosis or more HIV. This is the Galician Observatory for Public Health. And we are also working on digitalizing the entire public health system, and we've taken the first steps. That's all on my behalf. I'd like to once again thank you for the invitation and also for your attention. I'm sure you have given me. Thank you very much.
Thank you very much, Carmen. First of all, if any of the colleagues here want to take the floor, if you have any questions at all, the floor is yours. Otherwise, as I was saying earlier on, the people who are also online can also connect, and we received a question already, which is 2 parts. I think the question has been partially answered, and it says if Galicia is a reference region, and given the way the COVID crisis spread, how easy was it to contain the pandemic? And the question says whether we are now better prepared for future pandemics after this Tittan experience, be it COVID or any other pandemic. So in relation to that first query, I think it is fundamental that we have a long journey backwards in terms of digitalization. I would not be able to imagine how we would be able to manage this pandemic without our e-clinical histories. We had a lot of work done on digitalization. We could all connect online. We could all see what was happening in senior citizens' home. I don't want to imagine what would have happened if our referral and admission systems in hospitals not allow us to have a general picture of what was happening in order to find solutions. And obviously the tele-assistance solution that I was mentioning earlier on was absolutely key. This platform that was initiated for the follow-up of chronic patients and for healthy aging allowed us to also monitor the pandemic. So I think that without a doubt, having this past innovation and digitalization trajectory in Galicia allowed us to go faster and safer in the tracking of COVID. And with regards to the second query, whether we're better prepared now for another crisis, I think the answer is obviously yes, because we have experience with a previous pandemic, of course. If I knew now, if I knew back then what I know now, we do things differently, of course, but we cannot forget that we need to continue working in a public healthcare system that is powerful and resilient. Everything that we're doing in Galicia is changing the structure of the healthcare system. We've created the observatory, we've created the Public Health Institute. We developed different projects like the one we'll be introducing tomorrow. And I think this should make our public healthcare system stronger and more visible. If we cannot have a stronger public healthcare system, it is probable that we'll find similar problems in the future than the ones we faced and met when we had to face this pandemic. The interpreter cannot hear the question from the audience well. It is important that the speaker at the audience uses a microphone. the interpreter cannot hear the question that is being asked from the audience. I think there is no microphone being used. I think that we did that pretty well. Every week, in fact, we would talk to our citizens twice. Once the speech was given by the president of Galicia, he would communicate with the citizens and share about the measures that were being implemented. And then we'd have a press round in order to explain the measures that were being taken. So I think our communication was quite direct. And then we also used social media, for example, to communicate the initial vaccination campaigns, for example. And I think we worked pretty well at that level. And then we also had our website. I think something that we could improve was the type of information that we were sharing, because in every conference I've given since this post-pandemic phase started, I've mentioned that I think that from the public health care, we made a constant error. We had 35 clinical specialists in our technical team, but we didn't have a sociologist there or a psychologist. We didn't have communication experts. And I think that if we had these experts, we'd be able to communicate our messages better, because unless you know what the people need to hear, it is hard to communicate with them. Our communications were very clinical in nature. They were very medical. So I think that at that level we have room for improvement. And then there's also the website. Our communication in the websites need to be maybe easier. So I think that it is for that reason that we realized that we had to have a Galician public health observatory where all the information that one needs to know about healthcare is located, and it'd be better if we had that before the pandemic. If you allow me, Carmen, I also want to ask you one question. I'd love to have your assessment on how the response of the Galician population was. You gave an example around vaccination. Basically, the vaccination rate suggests people responded to the callings to get vaccinated. But then I wonder, what other companies did. I know that companies like Inditex offered certain products at a time when it was hard to get certain products from China, and then there were other companies that offered financing to carry out research projects. I wonder what your assessment is of the response coming from society in Galicia in general. As you were mentioning earlier on, and you were very knowledgeable about this, I think the response of Galician society was exemplary. It was incredible. The relative success of our management of this pandemic is linked to the behavior of Galician men and women. Their behavior was exemplary.
Restringía la movilidad, se cumplía.
I think citizens were very comprehensive. They were very understanding. People working in restaurants and in the hospitality sector were very understanding as well. They were very hurt financially by the pandemic, but I think they were very understanding overall. When the calling for vaccination was again exemplary, when we had around 97% or 98% vaccination rate. There were other regions that were finding difficulties to get people to go and get vaccinated, and we didn't have that problem. And I think the industrial sector in Galicia played an exemplary role, especially in the Wuhan phase, when none of us knew what had to be done. The industrial sector was extremely supportive. Purificación García, a certain company, gave us different equipment. Also, Inditex, other companies brought materials from China. They used their logistic networks to help out. I remind you that back then there were almost calls for tender for the equipment in the hospitals. It was huge investments were done also in the field of research and technology. And yes, I think that everything we have shared good practices wise come from a clinical perspective. I'd say that the best practice came from Galician citizens themselves. I don't know if there are any more questions. Otherwise, thank you very much, Carmen, for your presentation. And we'll now show a video that basically summarizes the good practices, the Galician good practices that we've shared within the Tittan project context. And then we'll give the floor to a colleague from the Basque Country, Xavier.
Irrumpe en nuestras vidas bruscamente la pandemia de la Covid-19. Para Galicia, donde una de cada 4 personas tiene más de 65 años, esto supuso un gran desafío. Pero se enfrentó al mismo partiendo de un sistema previo que ponía en el centro a las personas y apostaba por la innovación, la investigación, colaboración con todos los sectores y el impulso de las nuevas tecnologías, siendo una de las regiones españolas que más rápido reaccionó. Las buenas prácticas desarrolladas en esta crisis sanitaria que el proyecto Tittan ha tenido la oportunidad de estudiar y compartir han contribuido a que el impacto de la Covid-19 en Galicia haya sido uno de los menores en la geografía española. Este sistema novedoso en España resultó muy eficaz para testar más rápidamente grupos en empresas, hospitales y residencias, lo que ayudó a contener cientos de brotes de contagio, evitando tener que realizar 650.000 test adicionales. Esta plataforma, con la que ya contaba el Sergas para la telemonitorización a distancia de pacientes crónicos, adaptó sus parámetros para seguimiento de los pacientes COVID y de sus contactos sin necesidad de desplazamientos, siendo un canal de comunicación ágil y eficaz. Formación del personal, estrategia de comunicación, despliegue logístico y un gran apoyo de innovaciones tecnológicas como los códigos QR llevaron a Galicia a ser la región española con mayor porcentaje de coberturas en todos los rangos de edad. Con esta iniciativa se desarrollaron estrategias y actividades de apoyo y reconocimiento para la prevención de posibles problemas emocionales y de salud en el personal, asegurando la calidad del servicio sanitario. Los números reflejan la gran colaboración de estos profesionales con el gobierno gallego. Más de 195.000 recogidas de muestras para cribados PCR, con más de 3.700 positivos detectados, más de 140.000 autotest suministrados y más de 1.100.000 certificados COVID emitidos. Gracias a un complejo e integral sistema logístico, apoyado en innovadoras tecnologías, se pudieron gestionar al día más de 11.000 pedidos que fueron dirigidos a todas las unidades de consumo. Estos son solo algunos ejemplos de iniciativas gallegas que se han podido compartir con las regiones europeas que forman parte con Galicia del proyecto Tittan: Lombardía, Sajonia, Escocia y País Vasco.
Hello, everyone. My name is
Hola.
and I work as a program manager in the Basque Foundation for Health Innovation and Research, BioF, during the last 6 years. Today, I had the pleasure to give you some details about the next presentation of two colleagues, because here we are going to have the chance to listen about an example of a good practice selected for the Basque Country region in response to the COVID-19 pandemic. The title of this presentation is Teleconsultation and videocalls in Osakidetza. As you already know, the COVID-19 pandemic extremely affected the care homes residents and, of course, the professionals to the access to health and advice. The healthcare professional adapted rapidly to the challenging situation using the videoconsultations and several different platforms that were already in the market, depending of the specific needs and reliability of the technology and the support that this kind of platform offers the users. However, the data protection and data security were raised as a potential concerns for the final users. Igor Zavala, head of the Integrated of Care and Connected Services, and with my colleague also, Sergio Resino, head of the Healthcare Application for IT and Information System, both from Osakidetza Healthcare System, have led the inclusion of the video conferencing system within the framework of our healthcare system. And this solution helped to maintain the activity of our health professionals fighting against the pandemic, overcoming the limitation that the breakthrough of this pandemic create. So I don't want to use more time because I would like to give them the chance to give us further information of how this good practice help to overcome the situation. So please, Igor and Sergio, the floor is yours.
Okay, thank you, Xavier. Buenos días and good morning, everyone. Lo primero,
buenos días a todos. Good morning. It is wonderful to be able to share here our experience. Our experience is very humble, if you like, but we think it's going to be long-lasting time-wise. In the previous roundtable, our Galician counterpart referred to those old days that bring so many images of fear. So what we're going to share now, to a certain extent, I'd sum it up with two words. I'd like to highlight two words out of the experience. One of them is innovation, and the other is gratefulness. I think they're two very common words, but throughout the presentation, I hope that you will ultimately understand them. Within that context, we had to introduce new elements that would respond to a situation that was extremely complex and extremely difficult to handle. Each of us was called to find new ways to reply to that challenge that took the shape of the COVID-19 crisis. And one of the tools was the video or teleconsultations. In the Basque Country, we call them video calls. Sergio will later on explain why we decided to refer to the concept of video call instead. But when I look back, and at least in our service, we talked to doctors because we already had tools back then. So we were discussing about the possibility of doing teleconsultations. This was before the pandemic. And the clinical side of things, the clinical department did not really want to enter the realm of teleconsultations. So we had to have a pandemic to take that leap forward and move on to teleconsultations. So is that the case? Well, we'll never know. But the fact that we had a pandemic and that we had to find new ways to relate to patients was used by the system to, if you like, take this step forward and introduce this technique that we're going to introduce now. So this is just a context slide. As I said, professionals did not really want to introduce all these new technologies, but there were a number of professionals in our sector who back then, not from a corporative perspective, but from other points of view, they began to introduce this concept of video calls. There's a certain amount of literature that was suggesting back then that video or teleconsultations were safe and that they could help and they could be useful to manage certain patients. And it was a tool that was being used in hospitals already in some areas. So what we did back then was to say, you know, literature is telling all these things. Let us see if we can implement it in our own system. So in 2020, Sergio, is that the case? A group of us, a group of doctors and IT specialists began to work together to, you know, back then we were working with Zoom already, and we were basically trying to integrate the functions that we would require for teleconsultations through Zoom, and we'd integrate that with our clinical histories department. So that is the integration. Just integrating technologies, you know, is very essential, and it's not easy at all. So we did a small integration between Zoom and our Basque clinical history system, and I'd like to actually thank all of those professionals that were part of that first pilot project. So basically, what we did was design a pilot tool that would integrate Zoom with the online clinical histories. Then we assessed that experience. This was 2021 already, after carrying out those first designs that would match the clinical side of things and then the technological backup. And then we suggested a different set of improvements that would need to be incorporated in the following teleconsultations in Osakidetza. So in order to do that, we chose a number of professionals. They were around 25, and we tried to include a spectrum of patients who, you know, back then were mainly chronic patients, and, you know, there were other types of patients as well, but they were mainly chronic patients and patients with heart conditions and people who had to be at home because of the severity of their disease. Because back then, you know, those people would not go to hospitals, and many families did not want the doctors to go to their homes either, because they feared that the virus could spread. So we thought that the tool could be particularly useful with this set of patients. So we worked with different materials, both for patients and for the professionals in this pilot project. And in these materials, we would explain how they would need to use the different technological tools to both professionals and patients. And that is how we carried out over 100 teleconsultations between professionals and patients. And within an online setting as well, we also carried out different types of meetings. We would do interviews, online interviews to both professionals and patients. And the replies of these assessments are quite long, but we basically asked them if the tool was easy to use, well, whether in comparison to other materials and other tools they had, such as phone calls, for example, this incorporated an additional value, and whether they would repeat the use of a service such as video calls. And we received a number of pros and cons amongst those replies. So amongst the pros, the patient said that connecting via their mobile phone was not complicated. It was easy, they said. It had advantages over voice calls, it was very positive to be able to actually see the patient. They thought the image added value to the experience. For chronic patients who feared leaving their homes and go to either the public transport or go to hospital, many people were using, hospitals back then. So there was this fear of getting COVID in these settings. So not having to leave the home was also seen as valuable. And then these patients also said that this tool allowed them to sort out the problem that they had back then. They basically had a lot of doubts that they could ask. And then there were some other cons, some areas for improvement that we're now trying to sort out, which basically sum up as follows. Whenever the patient had technological doubts, we often found ourselves not being able to fully reply. And then there is also a fear that I think is lasting. And in the previous presentation, someone mentioned change management and how change management has to be managed. Basically, there is a fear that technology could replace the human factor, that people, stop seeing human beings, basically, and that be replaced by machines. Back then, everyone was using the phone. No one was going often to hospitals, and so the phone actually worked and it was useful, but it was also somehow diabolical because it prevented you from personally contacting your nurse or your doctor, and that generated a certain amount of fear and rejection. So this can happen as well with video calls or teleconsultations. This is something we need to know. And some patients communicated this to us because they would ask us things like, if I receive a video call, will I stop going to personally visit my doctor? They had doubts because we had not explained things to them. Everything was going really fast, so we were not really explaining things. So this highlights the importance of communication when it comes to incorporating new technologies and services, because we often have the tools, but knowing how to use them and knowing how to make people know that they can be useful is something entirely different that we also need to work on and focus on. So when our colleague mentioned sociologists and psychologists, I had to agree with him because it is very true. Someone else also said, I think this tool is great to do follow-ups. I can follow a patient and know whether, you have to remember that the Basque Country, like Galicia, is very green, but then it also has a lot of mountains. The weather can also be hard in winter, so forcing people to commute to hospitals for very, very short consultations can be questionable. These consultations we thought could be replaced by teleconsultations, and the majority of professionals, doctors, would tell us that they would if they could, they would continue using teleconsultations in the future. And the doctors also told us that teleconsultations should be included amongst the services of the hospitals, on-site consultations, video calls, and telephone calls. More training around the tool would be required. This is something that was repeated often. And this is something we should continue working on. And then patients also said that when it came to acute diseases, teleconsultations was probably not the best of tools. This is something we need to improve in the future. And as to learnings or lessons learned that basically sum up our experience, I think that teleconsultations constitute a good tool, but we need to define for whom and for what processes. It is not a coffee-for-all tool. COVID forced us to jump into the pool and swim, but now that we have time for reflection, I think we need to see and analyze what is the patient profile, what are the processes and so on. video calls have image, so they add up something versus voice calls. And I think that it does something more than just complement voice. I think it does constitute a good tool beyond this complementary factor. It is not a tool that is hard to use. This is what many people have said. I have my reservations around technology, myself, even though I use it. There are moments when I have my own question marks around how to use it, but basically these video calls seem to be pretty easy to use. But we should have maybe some reservations around its usage for very acute patients in the future. And then I also wanted to mention two additional things. When we began to use this tool, we began to look for someone, or some other healthcare sector that was doing video calls already. And that's how we started another European project with a Scottish partner. Back then, that Scottish sample was using a platform called Near Me, and we asked the Scottish how they were using the video call, what we should be taking into account in our own implementation project. And in this case, the Scottish experience was extremely useful for us to take that leap that we were not daring to take. So I think that these exchanges between regions in Europe they're extremely vital in order to make progress. And something else that we didn't do back then, but I think we should be doing from now on, is co-design. We did that in small workshops. We often had very little time for that, but I think that from now on, I think we should be counting more on the voice of professionals and also the voice of citizens when it comes to fine-tuning these services and tools so that they are closer to the needs of both professionals on the one hand and patients and families on the other. So this is basically a summary, and if you like, we can continue with the rest of reflections later.
Buenos días a todos. Good morning, everybody. Mi nombre es Sergio Lasino y trabajo en la subdirección de informática de la Dirección General de Osakidetza. El objetivo que quiero un poquito, primero gracias a todos por habernos invitado a este evento final.
Thank you for inviting us to this final event. We're glad to be able to share with you, with Galicia and the rest of the regions that are part of this Tittan project, to share our experiences. But I'd like to say that we're still piloting it. We're still testing it out, so to speak. We don't have much knowledge. We have a lot of knowledge about IT tools and so forth, but the pandemic has been very pressing. As Carmen said earlier on, all the workloads that the professionals have had, well, from the viewpoint of the IT professionals, I would like to say that during the pandemic, we've also had a huge workload because of the immediacy and how critical it was to adapt the IT tools that we had, clinical history, clinical records that have been electronic for a long time in the Basque Country. So while some colleagues were working to try to provide management and supervision mechanisms during the evolution of the pandemic, as Igor said, we had the challenge of trying to implement or design or to start to learn what video calls, video consultation was all about. So I'm going to show you my slides. Well, my colleague was just saying, and so it's going backwards. Let's have proper positioning. Could you go a little further back, please?
Bueno, mientras se posicionan los compañeros técnicos.
While the technical colleagues get ready, we had this challenge of how to integrate the video call and teleconsultation. What we did in this case was that we had the task was very simple from the viewpoint of functional viewpoint. We had our clinical record. We want to provide citizens with a new professional new channel or this interaction. And we had some problems because of lockdown and not being able to have physical calls. So we analyzed all the experiences that we had close to us, the case of Scotland, the case of other communities, and we saw the potential alternatives. One would be to go to some sort of a commercial solution that was not integrated. It would have been easier, perhaps, to use, but we were already foreseeing, given this study of prior initiatives that had been happened in different profiles and groups, the mental health care units, matrons, and so forth. But the entire use of technology by duplicating systems, if it was not integrated, it wouldn't be swift enough. It would give us problems, either for implementation or integration. So we had a clear goal, the IT and the directors, that we had to integrate this new healthcare that's called video consultation or video call. Of course, we had to test it out in a way that was not risky or that provided a saturation for the professionals that were already saturated themselves. So we designed this first pilot scheme to use video calls only for care, both primary care and also specialized care. So we designed this concept test by integrating the corporate solution that we see here, that we had already implemented during the pandemic, which was the Zoom platform. It was well known by most professionals in healthcare and also administrators on the day-to-day basis of many video calls using this tool. So we tried to mitigate the impact, and for a small group out of the 25 professionals, to start this pilot test by integrating the clinical record and leaving to one side, that we'll show you later, the solutions that we've implemented, the appointment scheme. And so we could see the experience of these professionals. So precisely what we see on this slide, more or less, the clinical record that you have on the right, the screen with the clinical records. As for the professionals, to make things easier, what we did was to have them pilot with appointments that they already had been given, either on the phone or face-to-face, because everything was cancelled during the pandemic. So they could pilot the integration and the opening up of this Zoom solution for video conferencing. So from the clinical record, what we did was to integrate in the solution of the clinical record with this tool, this video conference product, which was well known by our professionals. So all the professional had to do was, on an appointment already set, and that's what the pilot was all about, we would leave to one side all the administrative things on an appointment that is already called for the primary healthcare doctor or specialist. We could program further appointments with a very simple scheme. They could invite a patient to join this new channel, which was not face-to-face. And with this, we integrated our care platform to the video call solution. So the patient, the citizen, would reach this via different channels. We had an SMS sent or an email for the patient. Using a smartphone or a tablet or a personal computer, could receive the notice to access the video call, video consultation, as invited by the professional, and downloading using these measures, the free Zoom app. They could identify it and open up the video call. So this is the view of the patient, the clinical record. And here we have the professional can open video call channel to interact with the patient, and they could access all the necessary information. So this was more or less the aim of the pilot scheme, to integrate the corporate tool of a video call, a video conference, within the clinical attention that Igor mentioned. This was assessed and it was very positive. Of course, we saw that some improvements were needed, that we managed to integrate, especially in the appointment part, what we hadn't done. So we knew the pilot plan that we had carried last year in 2021. We knew that this solution for video call would have to be also integrated within the circuit of setting appointments for primary care and specialized care, to have it fully integrated and not add an extra cost by having to program apart from the video call, or to overburden the pool of users of the administrative area. So what we did last year and this year is to develop the integrated solution for the video call. And as Igor mentioned, we first called it a video consultation because it was more or less directed to the professional side of things, to have a proper consultation. But by looking at the forums that we were involved in at the national level, at the ministry, and with other regions, so we tried to open up the concept of teleconsultation, the video call, to be able to approach other kinds of access, not only for healthcare, but also administratively speaking. So we integrated the appointment side to the clinical record side. And here we prepared a short video. We would have liked to make a real-life demo that we have achieved in other editions. But for the sake of time, we couldn't do that, and we couldn't connect to our corporate system. So we prepared this short video to sum up the appointment scheme in specialized healthcare, and also the integration with the care bit. So we'd like to offer patients, in this case, it's better than just a phone call. So we use our corporate solution within the specialized area that we call Osakidetza, and we use, you can see how patients may wish to request an appointment by using a video call. In this case, what we're going to do is go to the reference hospital. I'm going to connect as if I were the administrative staff at the hospital. So now, when the system is loaded, our administrative personnel just has to identify and find the right patient. We have a patient prepared here, as I mentioned before. It's a fictitious patient, but you can see that he's got a name, but it's not a real person. In this case, the administrative staff will register the request, and by showing them the slip or identifying that they need a video call with a certain specialist, the administrative staff will offer the patient the appointment exactly as if it were face-to-face or telephone consultation. In this case, we're going to simulate a video call for the cardiology service. We're going to simulate that it's the first video consultation, although the video call is going to be integrated into the circuit as if it were another provision or a supplementary test. In this case, the system, as you can see, by detecting that it's a video call, the administrative staff is going to remind them that they have to confer with the patient. This can be done over the phone too. The contact details for the video call, you can see on the right the patient's data. There may be different contact phones or even emails to be able to identify certain information. In this case, what we're going to request from the patient is the patient to give us what their telephone number is through which we shall be able to send them an SMS to notice the access to the video call, or an email, contact email. The patient will decide whether he or she wants to use one or the other or both. In this case, we're going to simulate that the patient, we're going to change the telephone for whatever reason. There's a change of telephone. We're going to use the cell phone of my colleague Iger. So the invite and the notice of the video call will reach them directly on the smartphone. So here we go. In this case, as is done with any other consultation, we try to find slots, and instead we'll look through the agenda that has to be configured previously what the best slot available is for this case. In this case, we have an appointment for the 22nd of June. So if the patient, for some reason, cannot go there, the administrative staff will choose or select any other date, any other slot that is available and suits the patient best. So you can see here we have a fictitious agenda. It's true that each organization, each hospital can organize itself internally to book the minimum time necessary for the video call, combined with other provisions for each service. In this case, it's a fictitious agenda. At the moment, we're working with this. The idea is to create enough slots per day or per week for certain services. Let's take, for instance, the 9:30 slot on the Friday, 24th of July. In this case, we would confirm the appointment, and automatically the relevant patient will have received an SMS and or an email according to the notification channel that he or she has chosen for the appointment. In these terms, this is the confirmation window. So the patient has been given an appointment for Dr. Isabel at Friday, 24th of June. So this part has been done. It's ready. So what we have done is to integrate this app at the integration level with our corporate integration appointment system. Together with the primary care. So that's the first part. The second part we'd like to show you is especially when the day arrives, the professional, in this case, Dr. Ramos, who is in charge of this, will be seeing patients habitually, and this will help her access the corporate system and the electronic clinical record. So if we connect, in this case, Iger, who's acting as a patient, will have reached his cell phone, the SMS to remind him access to the video call, the link, and the password. In this case, we'll exit the administrative management system and we'll connect to the clinical care software. Let's see if we can connect. Here we have the system. If you're integrated, you can access external accounts or others. In this case, we have integrated the video call selection with external consultations, and the clinical staff will be able to access and position in the agenda that is providing the appointments now. Here we're using the clinical record. It's a fictitious patient, but our solution is integrated to different systems connecting with the laboratories, with the nurse care, prescription, etc. So you can see how it takes a little time to connect. So this is the first window that we have in our clinical system. So what we do is we position ourselves in the agenda. We're going to go to the cardiology service. Let's pretend that I'm the cardiologist that is seeing patients according to the Dr. Garcia Ramos's patients. So we have provided the appointment for the 24th. We see all the appointments that the doctor has on that date. So we go to the agenda connected to the 24th of June, Friday, and we see how, in fact, the patient whom we'd asked for an appointment for, and the patient had gone to the counter for external consultations to request the video call. The patient has been given the appointment. So all the professional will have to do is enter the clinical record as they would do with any other programmed appointment that they have on that date, both face-to-face and telephone calls. So if you look, we have the concept of video call also available. What you see here is the window for the clinical record of the patient that we have organized with different gadgets with different levels of information. And if you take a look precisely on the upper side, when you access the clinical record of this patient, Mr. Legarda, you'll see that on the top, we have been enabled the icon for Zoom for the video consultation. This means that the professional has accessed the clinical record of this patient, which is connected to an appointment the patient has connected to this video call consultation. So then the professional, whenever he or she wants, can open up the video call session, but may also open the window, or even during the call. We can see this in how the consultation takes place. You'll see what kind of records there are, what kind of activities have done, what analysis or anything. So this is a fictitious patient. I'm not showing you any real information here, but in this case, this fictitious patient, well, the doctor could prepare the information that is needed before the video call. Here we have all the analysis, the x-rays, or whatever a doctor can do. And then open the video call by clicking on the Zoom icon. So in this case, what we're doing is we are connecting a real appointment in a real slot for the cardiology service, in this case for specialized attention at the hospital of Uduri. And so we connect to the video call. So we ought to have the name of Dr. Garcia Ramos, who would have been the one to log in. But in this case, what I've done is to change her name by accessing her agenda. And what we're going to do is the professional would activate the video camera, and they would wait in turn for the patient who's been sent at least via one or two channels of identification this reminder of access to the video call. If you take a look in parallel, I don't know if we can show the camera, Igor, as we speak. So you can see how they're waiting with the cell phone. I don't know if you can hear me. Yes, I am. I can hear you, yes. Can you show us the cell phone so we can see how, as a patient, he's seeing from the Zoom from clients the waiting room until the professional, in this case, that is myself, gives access by admitting to the video call. Neither one is going to be admitted. I'm going to give them admission now. Igor, if you wish, you can activate your camera. And now the professional and the patient can exchange their impressions, and they can see their faces according to the condition that is being screened. Well, in this case, the healthcare professional may control to just see the patient's camera, and they may also monitor the video call and listen to the patient at all times, can minimize the screen if necessary. So while the patient says how the results have been or what problem is or how the patient feels, in this case it's cardiology, after perhaps the professional will be able to check the clinical records and make the necessary decisions. And at any time, they can reactivate the video call, and whenever necessary, they can say goodbye to the patient and close the session, both for the patient or the professional. If you want, Igor, since you're healthy, you can see that you are perfectly well and the video call has been a good one. What we can do is a successive review through this same channel, successive, or whether for any reason the patient does not wish to continue, they can also ask for a regular telephone consultation. So Igor, good afternoon. Please disconnect the patient's video call session. Press end or leave. If you see in this video call, the patient has already left, and he could also close and end the video call. This issue of video calls, as we mentioned initially, we started to pilot the solution as a video consultation, but to the purposes of healthcare, we thought it was necessary last year after the beta testing to be able to actually use this for other kinds of actions, and also to perform administrative processes if necessary. So after this video, which we will have summed up to the part of the administrative circuit and the use of video, just to comment the next steps, where do we stand now? So on the right, we can see the support of the care system and all the parts taking part. In order to do this, we've already dimensioned the technical resources. We provided the technological infrastructure. We've increased the broadband and all the necessary gadgets or widgets in the Zoom platform, or the plugins, sorry, and the licenses, and how important it is to provide support to the citizens. We're already setting up something for the citizens to be able to solve any doubts that they may have. As Igor said, we're fostering the use of video calls for care, but we also have a training scheme. In our next steps in this last quarter of the year, we're going to pilot the same solution that we showed you for the specialized part. And there you can see for mental health care, that's where we're going to be focusing. And before taking the step to integrating the video call system in primary care, we're also piloting the video call solution among professionals, given the geographical dissemination of the healthcare centers. So the patients may go to the healthcare center, but they can have a video call with a different center, always with the necessary professionals to manage the video call. Like we said before, we're also taking part in the standardization committees through the ministry. And this is more or less, in a nutshell, what we would like to share with you. I don't know whether you have any questions. No, thank you very much for your intervention. We're going to see the Slido because, of course, we have a lot of participation. We have a question that you have just more or less replied on the steps that need to be taken in order for video calls to have a key role in the future of health. But we also have another, which is about, we're told, the pandemic saw a deployment of technology for the citizens as well. Video calls became very common for everyone, and this helped to foster the implementation of these solutions.
Clearly, it was one of our fears. It was one of the main questions we asked in our surveys, and indeed the answer was that it was a source of help. Citizens used these IT tools for their meetings, work with relatives and so on. Yes, if you like, COVID with all its drama had a positive layer, which was that it forced private and public institutions and also society in general to take steps or leaps that would only be taken further on in time had it not been for COVID. In a way, the pandemic accelerated a process. It also eliminated certain fears around the use of IT tools. But in relation to that particular query on how we're going to take steps forward, we should say that this is an unexplored territory. Some people have ventured that territory already with better or worse results. It is true that tools are getting more accessible, but it is also true that we need to ask ourselves certain questions that are not easy to answer. For example, what about, all those data that are traveling from A to B? What about equity? What about territories that do not have access to a good Wi-Fi connection or who have no training, for example, in mobile technologies and so on? The public system has to guarantee that no one is left behind. And those reflections will probably need, amongst other things, certain corporative strategies, I'd say even government strategies. Our way of working, our current way of working, even though there's a strategy in the Basque healthcare system around technologies and so on, I think that this has almost been a bottom-up process rather than a bottom-down. The system was there, and I'd say that, we used what in English would refer to quick question-answer technique, which basically means that Sergio and me are connected with the subject matter 24 hours a day. We have tried to sort problems as they came with the IT team, with the clinical team. Beyond any type of strategy, we followed a bottom-up strategy, and I think it is high time that we start working more strategically, probably in a more reflective manner, so that we start giving answers to those big questions. And I think those will be the big steps, other than those short-term challenges, but I think these are the big questions that the Basque healthcare system has to deal with. I want to thank Mr. Igor and also Mr. Sergio for their ability and for your will to share this whole process, because I think that one of the most interesting issues that have been clear in your interventions is that you gave precise details of how these technologies have to be part of the healthcare systems and how you have been able to integrate this bottom-up strategy, final uses, those pilot processes, the gathering of feedback, the correction of the system in order to adapt the system to the citizens' needs. So, you created a really tailor-made strategy based on the needs of patients and the needs of the system. And I think this process you've described is very interesting. It is good to see how hard it is to implement and how you had to go through all these phases that can guarantee a success rate like the one you have bore witness to in your presentation. So I want to convey my gratitude for coming here to Santiago, to this last conference of the Tittan project, to share this good practice developed in the Basque Country. I think you worked a lot, 24/7, as you were saying earlier on. We also want to thank you again for your generosity in this presentation. I want to say that if there are other regions or communities that are doing similar things, we'd love to be able to share our achievements and our challenges, and we'd love to also learn from the progress made by other partners. So please make the most of this occasion to try to find out what others are doing elsewhere and get new answers. Of course, Tittan's collaboration does not finish with this project. We'll maintain it as a network for the future. So count on that, please. Thank you. Thank you very much to our Basque members. We will now continue with our Italian partner.
La ricerca biomedica. We would like to apologize on their behalf for not being able to travel to Santiago. And I would like to welcome the speaker who is already connected.
Yes, I am here.
Welcome.
Welcome.
Buona mattina.
Thank you.
Professor Pierikile Santos. He's professor in respiratory medicine at the University of Milano, Italy, and head of respiratory division at El Sacco University Hospital ASST Fate Benafratelli Sacco Milano. He was a member of the crisis unit set up by Lombardy region at the onset of the COVID-19 pandemic. And today he will talk about his work in the crisis unit, the measures and strategies that Lombardy region adopted during the early stage of the pandemic. So we are looking forward to hear from you. I give you the floor if you are ready.
Yes, I am ready. Thank you very much. Okay, thank you. Thank you for this kind invitation. And I am very happy to be here in this very interesting meeting. Now I share my presentation. I hope all will be okay. Okay. It's okay, my presentation. Do you see my presentation well?
Yes, we can see it.
Thank you very much. Thank you very much. Again, first of all, thank you very much to the Lombardy region for this invitation, and also to the Tittan interregional group, Europe. My presentation today will be focused on the practice in response to the COVID-19 during the first week and the first wave of the pandemic. So now we will see our experience here in Lombardy. The history beginning to the 20 February 2020, when at 5:45 p.m. at our hospital, Luigi Sacco Hospital, we have the first macrobiological test positive regarding to the patient 1 that after has been admitted in ICU in Codogno Hospital and come from Codogno to the Sacco Hospital. And this macrobiological test was positive for SARS-CoV-2 virus. Codogno is a little province of Lombardy, situated in the south of Lombardy. And after this positive test, immediate the situation came from the setup of a health emergency crisis unit by the General Directorate of Welfare in Lombardy region. And the situation has been organized with the crisis unit, with a task force represented by the epidemiological analysis, the enhancement of the laboratory network, the intervention on hospital activities, the situation regarding the equipment, the staff, the procurement, and the other point was the prevention related to the hygiene, living and working environments, the intervention on the territory and out of the hospital, and the legal aspects. So in the February of 2020, the General Direction of Welfare gives order to suspend it in all the Lombardy hospitals, the public and private, all planned intervention and activity, except those strictly not procrastinable. It's clear, this is a clear point. In the following days, the region crisis unit is joined by networks of coordination. The coordination of the intensive care units with the intensivists, the coordination of infectivologists unit, and the pulmonologist unit, particularly regarding the intermediate respiratory intensive care unit, the coordination of emergency rooms, the macrobiologist, and also the possibility to have a coordination regarding the ordinary acute inpatients unit, the subacute intermediate and rehabilitation units, the coordination of regarding the survey of DPI needs and the medical device and equipment needs. The situation came quickly from 20 February to the next days, because in 22 of February we come from 1 cases to 20 cases, and you can see here that the number of these patients was related to the Codogno and near cities, and also in Milan. But you can see here that 5 days later, we have a more increase, a very high increase of cases numbers, because you can see that the numbers was about 60, 70 patients, and the situation was enlarged, because not only the south of region was interested, but also the central, Milan, Bergamo, and also the north of the region. And 8 days later, the situation was very hard, very difficult, because we have had a very high number of positive patients that have had a necessary inpatient situation and assistance. And you can see also that in 3 of March, the situation was more critical, and the patients, the positive patients, were an high number. not only in the south of region, but in the second point to the region of Bergamo, the north of Lombardy. And again, the more critical situation. Here, the organization of the shock that come from 20 to 29, the first 10 days more or less. And this situation have had an important impact on the territorial emergency system and on emergency room and the emergency department. And you can see here that the situation, particularly from the first 15 days of March, was characterized by an important increase of the patient that come to the emergency room and in the hospital. And you can see here in the right of the slide that particularly not in the south of region, but in the north of region, the yellow line here, promote a very, very high number of patients that come in the emergency room and in hospital. All these patients, or more or less the 90% of these patients, have had a respiratory failure, a very severe respiratory failure with the need of oxygenation. And so the organization have had an important need of oxygen also in all the hospital. And here the number of daily access in the emergency room. And again, you can see here that in these times, during the first part, last part of February, first part of March, we have had a very high increase and improvement in presence of patients in the emergency room. And again, here the other slide that identify this point, but particularly underline that the most number of patients were represented with the patients that come in the hospital with a red on the yellow code. So the very severe respiratory failure. So it's clear that during the first part of March and April, from 1 March to 15 April, we have had a disaster situation with a need of a disaster plan. We have had an improvement of diagnostic laboratory activity. And so the organization of the region, the Lombardy region, and the welfare direction has been focused on the improvement of the laboratories that are good for the diagnosis. And this laboratory improved from 3 to 60. The comprehensive reorganization of the hospital network has been the second point. And the organization promoted the hub and spoke network of time-dependent pathology network in the emergency phase, and the centralization of the remaining urgent and non-delayable surgical activity, resulting so in a temporary transformation of some ICU and specialty ICU into general ICU and general ICU for boarding the patients with COVID and severe COVID with respiratory failure. And you can see here that during the March 2020, we have had an important, a dramatically increase in ICU patients that come from about 100 patients, more or less, to 1,300 patients. So 100 more patients in the ICU. And this was a very dramatical situation, But the situation is not, or better, was not so different also in the intermediate respiratory care unit. Why? Because we have had, you can see here, a dramatically also here improvement in patients with the need of non-invasive ventilation with helmet, CPAP, or the mask. And so the need to have also a coordination in the crisis unit of this setting, the intermediate care of respiratory patient managed with the non-invasive ventilation. And you can see here that the patient come from the beginning to the end, from the the end of February to the beginning of March. The patients come in this unit from about 500 to 1,900 patients, and constant the median, the mean number of patients. During the last months was height more or less 900, 1,000 patients in this situation. And also here the number of patients in the general wards, with a number of about 12,000 patients in hospital, recovery in hospital for different situation. And here also, again, the number related to the intensive care unit. So it's clear that the innovative solution were fundamental. And so the huge and sudden increase in ICU and the intermediate respiratory care unit beds was made possible by a number of actions. The number of actions were, first of all, the immediate suspension of scheduled hospitalization ordered as early as 22 of February. Second, the reduced number of referral centers for time-dependent pathologies. Third, the centralization of the remaining urgent and delayable surgical activities. The adoption of innovative, flexible, and extremely rapid technical plant solution. The occasional use of intensive care station within operating quarters. And in the end, the continuous and efficient coordination of the network of intensive and intermediate respiratory care beds. And in the crisis unit in Lombardy region, we have had the coordination again for a long time of intensive and intermediate care respiratory unit with the need to manage the recovery of patients, the solution from one city to the other city, so the possibility to have the patients that come from the north of Lombardy that were recovery in the south of Lombardy or outside the Lombardy region. So the very confused, very hard situation. So the overall network reorganization has been, or better, is here reported. And you can see here that we have had 3 dedicated hospital facilities for greater trauma, 4 for urgent neurosurgery, 10 for stroke network, 13 for the ischemic heart disease, 5 for cardiac and vascular emergencies, 2 for orthopedic emergencies, 2 for oncological emergency, 5 for the maternal neonatal network, 1 for neonatal intensive care unit, and 1 of pediatric facilities. So I think that this situation has been possible in the region of Lombardy because the welfare, the health system in the Lombard region was and is very good organized and have a very good organization. So the possibility with an hard effort, clearly not easy, but with an hard effort, has been possible to change, to modulate regarding the situation. Here, the situation regarding the pressure, the situation regarding the respiratory failure on the health system, Lombardy regional health system. And you can see that the most hard time has been related to the end of the February to the beginning of the April, and particularly with the up situation, with the more intensive, more hard situation during the March, with the very high number of patients that have a respiratory failure regarding COVID. So after March, we have had the phase 2 related to April and June 2020. And in this time, we have had a gradual increase in inpatient and outpatient activity. But I think that the more interesting, the more hard situation in this phase has been the outpatient activities. The situation regarding the situation for the rehabilitation, for the long hospitalization after the acute phase of the patients affected of the respiratory failure. So the regional communication of 21 April authorization underlined the situation regarding the authorization for facilities to plan and a gradual and progressive increase in inpatient and outpatient activity in the short term, particularly regarding the outpatient activity. On the hospital for the long hospitalization, long-term health organization, and the outside activity regarding the general practitioner or the telemedicine. I heard before in the previous presentation the importance of the telemedicine. And at the beginning of May, we have added the other regional communication where has been approval the criteria by which public and private providers should direct their activities, keeping activity temporary, areas of patient receptivity, especially intensive and semi-intensive, to cope with any sudden increases in the epidemic curve. The hospital network or reorganization plan regarding the release of June 16, 2020, employ time networks, priority criteria for identifying services to be performed, the centralization of highly specialized and major surgery activity, territorial emergency and inter-hospital transport network investment plan regarding the intensive care unit and the intermediate respiratory care unit. The graduality of the hospital network response has been related to the level 1 of the hospital network and the in-hospital facilities, both for public and private hospital, with the following skill and availability, represented by the experienced and dedicated intensive care unit, the infectious disease unit and teams, and near the intensive care unit, the pulmonologist unit regarding the intermediate respiratory care unit for the non-invasive ventilation, both with helmet CPAP and non-invasive ventilation with mask, and also the level 2 or the level 1 by the emergency department. So the response of healthcare personnel and the entire regional hospital system has gone behind expectation, and a careful analysis of what happened can teach us how to respond even better to the care needs of patients in the epidemic and post-epidemic phase. So I think that in conclusion, I think that in the Lombardy region, with the hard activity of all the welfare direction and the crisis unit, I think modestly that the Lombardy region have had an important role in this pandemic, and probably have had an important role not only regarding the health system, the patient management, but also regarding the scientific evidences. So I have concluded my presentation, and again, thank you very much for this kind invitation and for your attention.
Thanks a lot for your enriching intervention, Professor. I'm going to review. I think there are several questions for you. The first, what lessons learned from this experience do you think should inspire the future health systems and policy development strategies?
But yes, it is not my clear work, this one, but is the work regarding the region system. But I think that this experience has been very interesting in terms of some points related to the importance to have a network from the different hospitals in different sites of the region, the importance to have the different skills in different hospitals, and so the importance to have the hub and spoke for different situations. For example, it's clear that all the ICU come from different patients to the patient with respiratory failure and ARDS related to COVID-19. For the other units, the situation has been different. And so the experience of a COVID pandemic teach the importance to have different skills for different situations. For example, it's clear that the intermediate respiratory care unit are the unit that must be managed by the pulmonologist. The other setting related to the more for the other patients with not so hard is important to have a management for infectivologist or internist. So I think that this situation have had an important point or an important situation in order to have a new paradigm, a new possibility to organize the health system.
Okay, and another question is, do you consider that that your experience as the first European region to be affected helped other areas at the beginning of the pandemic to prepare for it?
Yes, our experience has been important, not only for the Lombardy region or the Italy, but for all the world. So, for example, our hospital have had an important network with the Chinese colleague in terms of management, but also with some other states, other colleagues, not only regarding the situation related to the health system, the organization, and the clinical situation, but also with the scientific evidences. Because, for example, in my personal experience, I, with my group and my equipe, we published a paper in the March of 2020 regarding the possibility to have a management of non-invasive ventilation with an operative flow chart. And so I think that this situation has been important for some other country in terms of health management of these patients.
Okay, thanks. And the last question is, what was the method to qualify the 60 laboratories? How did you coordinate the analysis and results?
Okay, regarding this question, I don't have a global answer because I am not a macrobiologist, but during the crisis unit meeting, I remember that all the macrobiologists discuss regarding this test related to the specificity, the sensibility, to the possibility to perform an high number with a good performance of this test. And so the epidemiologist, the hygienist, and the microbiologist and the infectivologist work in the more restricted group in terms of identify the laboratory. But the identification has been related to the skills, to the possibility of healthy person and equip, and to the quality, the possibility to have a high quality of the results regarding this test. But in the end, again, I want to underline that in my opinion, the work that has been performed in the Lombardy region during these first 2-3 months has been a very good work. Not only because I was present in the crisis unit or because I live in the region in Lombardy, but I lived the experience. I seen the importance and the work of all the persons included in this team, both the politics, both the technicians, both the medical doctor of all the specialties. So I think that has been a very, very good and even if hard work.
Okay, thank you again. It was a pleasure to listen to you. Now, at this point, I think we need a coffee break. So we are going to to have 20 minutes for coffee break. And after this break, we are going to have the remaining presentations from Scotland and Saxony. Okay, so enjoy your coffee.
Enjoy. Bye-bye.
Bye.
Bye, Professor. Bye.
Thank you.
So now with more energy, we will continue with our partner from Saxony, Healthy Saxony. The name of their presentation is Good Practice in Response to COVID-19 Regional Hospital Clustering in a Healthcare System with Independent Hospitals. The person who is going to tell us about Saxony experience is Dr. Olaf Müller from Healthy Saxony, the Healthy Saxony manager. So welcome, Olaf. We look forward to hearing your contribution. So the floor is yours.
Thank you very much. Let me share my presentation. Can you see it?
Yes.
Okay, yes. Perfectly. So thank you very much. It's a great pleasure to be here, especially as this project finally comes to a successful end. Today I will present you some information about Saxony and its response to COVID-19, especially in the first phases, the first waves of the pandemic. First, in order to understand what I'm telling you, a few side informations about German healthcare system. Very much unlike what we've heard today, the Saxon and the German healthcare system works rather independent, rather self-governed. So there's no immediate state control or regional government control over health and care assets. Hospitals and GPs are, I would say, independent. The word is not entirely correct, but are rather independent, are in a competitive system and are not in direct control of the respective government. This is important to know because otherwise a clustering would not be much of an innovation. But in the onset of the pandemic, there was a rather rapid response in Saxony between the three largest hospitals, which is the Dresden University Hospital, the Leipzig University Hospital, and the Chemnitz Municipal Hospital. All three about 1,200 to 1,400 beds each. So the three largest, they are geographically well distributed. And despite them usually being in some kind of competition, especially at the top level of medical expertise, they very swiftly organized the groups of hospitals around them in these three regions I will tell you about in order to cope with the pandemic. So Saxony as such is one of 16 Bundesländer. It's about 4 million inhabitants and has about 76 hospitals of different sizes. And these three I mentioned are the largest. So when things became more difficult, meaning infection rates were rising, ICU admissions were rising dramatically, the heads of the three largest hospitals coordinated amongst each other, also with the State Ministry of Social Affairs, which is our local or regional health ministry, and devised a solution in order to prevent a critical overload to the ICU units. Because if that would have been the case, you all know what that would have meant, triage and people basically dying where it would not have been necessary. So what was devised? There was a plan to divide Saxony into three parts, three regions. On this picture you see a red, green and yellow region, each with one of these three major hospitals in the lead, which is basically also the innovation. So they devised a hierarchical system, or per se hierarchical system, where the local largest hospital is more or less in control of its cluster and can decide or negotiate or arrange reallocations amongst its cluster. This is kind of new because any kind of hierarchical actual control and decision making on a top-down level is completely unheard of in the German healthcare system. But in this case, it was absolutely necessary because in the early onset of the pandemic, there were huge differences in cases of disease in ICU admissions within these clusters. So a reallocation prevented the local smaller hospital from being overrun. This worked pretty well. All three sectors defined, or three clusters defined their specific critical levels where they would need help from another cluster or on a national level. These critical levels were defined according to the actual capacity within this cluster and was defined for the Dresden area, for instance, at level of 500 normal admissions and 170 ICU admissions. These levels were designed to prevent the whole cluster from being near or at capacity for too long. Very early in March 20, a coordination center or coordination control center was created. For instance, I'm mainly speaking about the Dresden center, of three sectors or three clusters had their own center. And these coordination centers or control centers operated 24 hours, 7 days a week, more or less until now. Their tasks, their most important tasks, were the central management of the bed capacities within this cluster, which is a major innovation for a German health and care system, hospital level. Also for distributing COVID-19 patients within the cluster according to the specific needs. So if it's a kind of a complicated respiratory condition, they would ship the patient to Dresden. If it's possible to handle the situation in a local hospital, they would leave the patient there. And they also organized a strong network of medical consultations to make sure that each patient is where she is treated best. Also, very important, the redistribution and allocation of specific material that was needed, like hygiene suits, masks, test equipment, respiratory devices, etc., was redistributed and allocated from these control centers, or by these control centers. Since March 19, the actual workload was about 22,000 dispositions and redispositions of patients within the Dresden cluster alone. Also some 9,000 inquiries about COVID-19, about reallocations, about situation assessment, etc. But also 500 specialist consultations that were reallocated between the one that was in need of a consultation, like a smaller hospital, a GP connected to a specialist in one of the centers. Also bed reports, employee testing, etc. Also something that is devised early on. It's the IVINA system, which is connected to the first responders, giving the hospital where the patient is about to be admitted more detailed information about who is in the ambulance car, what's its condition, where it's going, and about the timing. Also, stroke informations were rechanneled to this control center, different from where the information would go before. There's a pretty good and pretty smoothly working stroke network in Saxony, and they redistributed the information channels to this control center in order not to miss any specific conditions of specific patients. In peak phases, there were about 120 calls per day of different length, different complexity, running through this center. Only the Dresden center, or the other workloads and the other two centers were more or less the same. In order to provide also the political level with some information, which in turn would provide the general population with some information, there were several dashboard-like overviews created. Also for the three cluster administrations, what was the workload? What's the bed capacity? Are we near or at any critical levels? Do we need to change something? Like on this picture you see here, for instance, on the top you see the four pillars of is it a pillar if it's horizontal? I don't know. The 4 graphs depicting 3 clusters and Saxony in general, where you can see that the Chemnitz cluster at this very moment is at capacity and is basically some reallocation already needed and discussed, for instance, between Leipzig and Chemnitz, in order to keep the system, keep the Chemnitz cluster running. On the bottom, you see the same logic, but for ICU patients, which shows a way more critical situation. This is showing the actual situation, which is important, but one of the major achievements of these clusters was to provide information about a forecast, a pretty consistent forecast showing the situation in 1 to 2 weeks ahead. As you probably know, in Germany, there's the so-called Robert Koch Institute, which provides information and the communication of averages about the COVID-19 situation on a national level. But aside from that, mostly all Bundesländer had their specific reporting, their specific forecasting. So had Saxony, and still has. And the Saxon forecast provided rather accurate, especially on the short to medium term, 1 or 2 weeks ahead, which made reallocations and quick reactions possible and precise at the same time. This is one of the reporting dashboards you see here, rather quickly developed, showing the actual admissions, actual occupied beds within the 3 clusters. And on the left, the Dresden University Hospital. This is from a later day. It's in March 22, so it's way, the situation is way lower, way cooled down. And what this picture also shows is a general change of the situation to the last report. So you quickly see any changes in between the days and the situations. And on the next picture, this is the already mentioned forecast system. So there's a prognosis of 1 and 2 weeks ahead of how the bed and the occupation situation is going to develop according to several key figures, several, I wouldn't call it key performance indicators, but you know what I mean. So in order to know what is going to happen in 1 week, in 2 weeks, which gives hospitals and hospital management in a better situation to, for instance, begin organizing more ICU beds, changing the station or the ward occupation, changing department occupation, changing staff plans, etc., to be able to react to the situation that's about to come in a week or 2. A third rather remarkable innovation was the inclusion of a wastewater monitoring into this forecast. There was ongoing research about disease germs or disease traces in wastewater already before the COVID-19 pandemic. And they quickly changed the measurements and the detection algorithms to allow for COVID-19 detection. And this proved rather interesting, pretty precise forecast about what is going to happen in some time to come. And this was actually included in the general forecast dashboard system, again, as another key figure to be able to cope with the situation to come, not to be overrun, to react accordingly, also on a downward slope. So to allow the personnel some time to rest, to recreate, because as all of you know, the very difficult situations during the pandemic were mostly solved not by administration management, but by the actual care personnel and the doctors on the beds. So this is one of many instruments that were devised to try to help those at the patient, trying to treat the patient, trying to help them. It is one attempt to solve critical situations, Another attempt that would have helped much is finding way more care personnel, but on a short term, this is basically impossible, especially during a crisis as such. So trying to organize the means you have more effectively during means like this, during forecasts like this, was one of the attempts that were successfully tried and successfully piloted in Saxony. What have we learned? All of the clusters, basically the cluster organization, the cluster plan is ongoing. So it's kind of a critical blueprint that is being kept for the next crisis situation. We learned that the particularly low vaccination rate and the high age average in Saxony made us suffer more on a German average. Now we know the load limits of each of the clusters. It's good to know for the next time. We also learned that scientific correlations are still not entirely clear on a medical and biological level, which needs some further research in these areas. Also, what on a national level was more or less neglected, let's call it neglected, was a correlation between the incidence and frequency of testing that has been taken in account in Saxony, but not on a national level. This is something that possibly other regions could learn. But also that the public health system in general was mostly unprepared. I'm not speaking about hospitals as such, but the public health information systems, the administrative health system, like it's called Gesundheitsamt. It's kind of a health agency in informing the general population what to do, for instance, if they receive a positive PCR test. Things like that, they were completely unprepared of a situation of this magnitude. Also, there were interesting developments on the level of competency division between the national government and the regional state governments. So there was lots of efficiency lost in this process of friction. Also that the centralized approach is rather inefficient in terms of acquiring needed material, of decision making. It's much faster on a regional Bundesland level. And what I also said, Robert Koch Institute average observations were not that accurate and not designed for actual regional control and decision making. Most of these points unfortunately led to some kind of discontent between the general populace with the ongoing time of the pandemic. So there, especially when means on a national level were publicly discussed, pros and cons of these means of reactions were publicly discussed, and decisions changed from one week to another, leading to completely different situations, for instance, regarding lockdowns, etc., led to discontent amongst the population. Next time, hopefully, policymakers know better and react different, but you cannot know. Okay, this was a quick overview of how Saxony tried to respond. We had the lucky, can you call it lucky situation? We were lucky that we were hit late. We heard Lombardy already. Greatest respect of everything that was done in Lombardy region. This was a completely different situation. In Saxony, we were basically pre-warned something is coming. We didn't do much of this pre-warning, but still it helped. I would not like to speculate on how it would have gone the other way around. This is basically something for the academics, they can do that. But I'm here for any questions, and thanks for listening.
Okay, thanks, Olaf. This presentation was very inspiring. The great change that your system suffered was essential, so congratulations. We are see if there are any question in Slido. Here there is a question. What other changes do you think should be made in your system to face with the challenge of the future, the aging, new pandemics or new waves?
This is a difficult question.
Yeah.
The general system as such is not meant for hierarchical control, as I already mentioned. So what I would suggest, or what I would try, is to allow on a national legislation level, basically all the health and care system rules are made on a national legislation levels, but only as a kind of a framework. I would change the framework to allow for special situations like these, in order to be able, so should a situation arise again, this is the next pandemic, specific plans are enacted, like general clustering of hospitals throughout Germany, things like that. So to make it more proactive. Now it was reactive, it worked, but it was reactive. General legislation could try to learn from the pandemic, from the reactions during the pandemic, and change things into national legislations to make them proactive and faster the next time a situation like this should arise.
Okay. Thank you again for your input. It's now time for the next intervention of our latest partner from Scotland, DHI, Digital Health and Care Innovation Center. They will present the following topic: good practice in response to COVID-19, decision support COVID-19. We are pleased to welcome Pamela Money, the program manager of Digital Health of Care Innovation Center, and thank her for her presence here in Santiago. Pamela will introduce the presentation and the speakers from Scotland. So, Pamela, it's your turn. Thank you very much. I give you the floor.
Okay, thank you. Hi, so I'm Pamela Mooney. I'm the Programme Manager in the Digital Health and Care Innovation Centre, and my colleague who's on the line is Anne Wales, and she's the Programme Manager for our Decision Support Programme. So I'm just going to start by giving some context on the digital health and care landscape in Scotland and how that related to the Decision Support Programme. And then Anne will describe the Decision Support Programme in more detail and do a quick demonstration at the end of that. So for those of you who don't know us, we are the Digital Health and Care Innovation Centre, and we're one of 7, sorry, I'm not sure, could we flick forward the slides? Have I got the, thanks. We're one of, thank you. We're one of 7 innovation centres in Scotland. We are, get this, there we go. Great. We are a national resource. We're funded by government, and the Decision Support Programme sits within the DHI. So our role basically is to work with a whole bunch of stakeholders, including the National Health Service, local government and social care partnerships, charities, private sector and citizens, to basically collaborate to create digital health and care innovations. And essentially one of the things we have to do is put the tools in place to enable those interventions to be rolled out at scale across Scotland. So our portfolio addresses the key health challenges identified by Scottish Government. The slide's gone a bit skew there, but essentially there are a number of areas there that the Decision Support Programme has also touched on over the years. One of the key areas obviously we're going to look at is the COVID-19 response, including service mobilisation, and the decision support had a key role in that. So Scotland has a population of about 5.5 million. About just under 500,000 people were aged over 65. And because this was the most vulnerable group, obviously the COVID response provided interventions to very much protect this group and treat this group with care. So the Decision Support Service did this through a couple of areas. It helped clinicians in decision making to provide excellent clinical care through the provision of digital tools, and it also did some support for citizens in self-management. Okay, so what does the digital health and care landscape look like in Scotland? Essentially, we have a challenge in DHI and across Scotland. We have some fantastic innovations which we can roll out on a small scale, but it's always been challenging to get it rolled out at scale across the whole country, although we have had some success stories which were limited before COVID. So governments around the world obviously tend to chunk up countries to deliver public services into areas, and Scotland's no different. And we have 14 health boards and 32 local authority areas. Our health boards commission and deliver healthcare services, and the local authorities commission and deliver social care. So one of the key challenges we had before COVID is that each geographical area can have differing demographics, different priorities, and therefore different pressures. And within each area, there are also different systems. So those include not only different IT systems, but there can be the same IT system with a slightly different version. And also we have differences in the systems of care. So the pathway that a patient or a citizen goes through to receive health or care can vary from region to region. So this in Scotland has made it difficult to do things once for Scotland, to deliver at scale across the whole country. And that's something that the COVID pandemic brought about. And we were able to do that because for the first time, all of these areas had the same objective of dealing with COVID-19. So we have a saying in English that every cloud has a silver lining, and certainly, a crisis can bring about progress. And this is something that certainly happened in Scotland. In the top left, sorry, I've forgotten to move my slides forward. We have fellow Scot Alexander Fleming, who discovered penicillin in 1928. So penicillin was around for quite some time, but it wasn't until wartime that this was really recognised and started to use at scale, and now is obviously used globally as a key part of medical treatment. So it's been the same for digital health and care in Scotland and beyond. The progress of digital health and care in Scotland has really been catapulted forward. And most importantly, through the COVID crisis, it's really increased the appetite for digital health across all of our health boards, and also just increased the recognition of what can be achieved through digital health and care. So just finally, just some other additional areas where we had some improvements in the digital health and care landscape in Scotland as a result of the COVID pandemic is that we used to have issues particularly around evidence. So people in the system, senior management who hold money to enable service redesign and the implementation of and commissioning of new digital health and care services. Well, they always need data to take the risk out of those investments. They need data, they need clinical health outcomes, they need to understand health economics, they need to understand the return on investment related to their financial investment in digital health and care. So this has always been quite high risk for those groups, and again has delayed the scaling up of digital health and care across Scotland. But during COVID, delaying or not doing anything was high risk. And actually the tables turned, and so management was forced to act at the most senior levels in healthcare and government to make those investments in the digital interventions. The other issue we've also had is that often organisations were just not ready for change, and we talked a bit earlier about change management, and they just were not ready to embrace digital adoption, and staff were not really released to put the time into doing that service redesign because it wasn't seen as a priority due to other priorities and pressures in the service. Again, that transformed through COVID. Staff time was protected to embrace digital, and really, ready or not, it had to be embraced because digital became the only option, particularly around face-to-face delivery for a lot of services. So all of that has really enhanced the digital health landscape, which helped the decision support programme. But one of the reasons we wanted to use this, explore this example in more depth, is decision support had already achieved some scaled projects across Scotland or multiple health boards prior to COVID. And what we realise is that its structure had made it agile enough to move at pace and deliver at the right time, in the right place, the support that was required for health and care staff and citizens. So it's been a fantastic programme, and I'm going to hand over now to my colleague Anne Wales, who will tell you more about it in detail.
Okay, so thank you very much indeed, Pam. I'm just going to try and share my screen now. If you can stop sharing, if that's okay.
How do I stop sharing?
I think you have stopped. I think that should be okay now, I hope. Thank you. So I'm just going to share my slides. Can you see my slides okay? Pam, can you see my slides all right?
Yes, yeah.
Okay.
Oh, sorry, no, actually, Anne, kind of. Yes, yes. Here we are, they're up now.
Yep. Up now, okay, thank you. And if I move them on, can you see them all right? Are they moving okay?
Yeah, they're moving, yeah. That's
okay, that's great,
Thanks,
thank you. So thank you very much, everyone. It's a pleasure to be here today to talk to you about how the National Decision Support Programme offered support for the COVID pandemic. And a real privilege to be here at your final Tittan COVID-19 conference. So first of all, what do we mean by decision support? Decision support takes the form of digital tools that enable people to make safe decisions quickly on the go based on validated evidence. Decision support tools work through day-to-day technology, for example, web and mobile apps, and embedded in electronic care systems. Decision support has been described as a sat-nav for the care journey because it supports that decision-making on the go as part and parcel of daily activities. The mission of the National Decision Support Programme, which I manage, is to provide a Once for Scotland national source of digital tools that empower professionals and citizens to make the best decisions possible about their health and care. The Decision Support Programme is a key objective within our national digital health and care strategy shown here, and it's also a key aspect of Scotland's AI strategy. A key vehicle for delivering the National Decision Support Programme is this Once for Scotland National Decision Support Platform called the Right Decision Service. The Right Decision Service basically is a collection of tools and interfaces. Firstly, knowledge translation tools that we can use to convert guidelines, validated research, best practice experience, and large data sets into computerized knowledge format. Often that computerized knowledge takes the form of rules or algorithms, but as you'll see in the examples I share with you, the computerized knowledge can take other forms as well. It can be summarized guidance, it can be visualized pathways, it can be tracking and monitoring tools, and shared decision aids that can be used by the patient and the professional to come to a shared decision about what's best for the individual. All this computerized knowledge is held in a single repository from where it can be combined and organized for delivery in different ways. Firstly, as web and mobile apps, standalone applications, and secondly, as algorithms that interface with care record systems. An important aspect of our platform is that many of the core tools can be used by information and knowledge staff and by healthcare professionals who don't have programming skills. So we don't need to be constantly commissioning new technical development in order to deliver new decision support. We can be fairly self-sufficient. So key features of this national right decision service that enabled us to mobilise it rapidly for COVID-19. Firstly, the fact that we already had a robust existing national infrastructure that enabled delivery of COVID-related decision support across all parts of Scotland's health and care. Secondly, our distributed management model. So the national team that sits with myself, we provide the platform, the infrastructure, we provide initial setup of tools, and we provide training. But it's the local knowledge managers and clinicians that do the maintenance and updating, and often it's those knowledge managers and clinicians who also do the initial populating of the decision support tools with content. This ensures local ownership and governance are in place, and also that the workload of our small national team does not limit the rate of uptake. So that clearly enables us to achieve scale more readily than if we were dependent for every aspect of delivery on a small central team. Linked to that is our self-service model, where no programming skills are required for many of the decision support tools the platform delivers. We already had a pool of knowledge managers and some clinicians who were trained in using the translation and app publishing tools, and that in turn enabled flexible and cost-effective delivery at scale. So what did we deliver? 3 groups of COVID-19 decision support tools. Firstly, web and mobile apps for local guidelines and pathways. So 5 boards have delivered those local COVID-19 apps. Secondly, mobile and web apps for national use, national guidelines and pathways. So we have 3 of our right decision apps that have been developed with our national guidelines body for NHS Scotland, called the Scottish Intercollegiate Guidelines Network, or SIGN for short. 2 of these apps are for professionals, one about primary care assessment, one about long COVID management, and there's 1 app for patients for long COVID self-management. There's also 1 national toolkit for mental health developed by the Royal College of Psychiatrists and Greater Glasgow and Clyde. Thirdly, we have algorithmic tools that perform calculations on data that's entered into the tools. 1 for delirium screening, which is the FORAT screening tool, and Restore 2, which is an algorithmic tool used for early detection of deterioration in care homes. So in total, there's 10 apps. It took me a wee while to calculate all of these myself. This is the timeline of development. So the global pandemic was declared on the 11th of March. By a 3rd week in April, we had the first COVID app with local guidelines and pathways for NHS Lothian built. That took just a couple of days because we had all the tools in place. They had the content, and we were rapidly able to populate the app and publish it for local use. It's followed some months later by Lanarkshire's app, then the Glasgow COVID app, and the national COVID app for primary care assessment. Into 2021, we produced the delirium screening risk assessment calculator, which has UKCA marking. That's our equivalent of CE marking following Brexit. In September, we were able to produce the long COVID app for professionals. That was based on national guidance produced by SIGN and by NICE in collaboration. And in December 2021, we launched the national long COVID app for patients. So it was a fairly continuous stream of work coming through. To show you a few examples, local COVID guidance. This is Lanarkshire's app. This is Greater Glasgow's. This is Lothian's. This is NHS Borders. And just to show you the web interface, all of these are delivered both as mobile and as web applications. This is the NHS Highland one that you can see here. For the national COVID guidance, this is the web interface to the long COVID guidance for professionals, and this is the mobile app for primary care assessment of COVID-19. I'm going to be brave and try and show you on my phone the patient-facing app for long COVID. So if you bear with me, I'm just going to come out of this screen sharing and try and share on my phone. I won't take too long if it's not working. Share my screen. So all going well, you should see shortly the screen come through. Good, seems to be working. So this is the patient-facing or citizen-facing app for management of long COVID. Some aspects of it are a very simple informational text, as you can see here, but formatted and presented to be readable and understandable by patients. So there's been a big piece of work to translate professional guidance into information that's usable by the general public. And then we have the symptom diary, which I'll just go into. There's three parts to this: one area for recording your symptoms, one for free text recording about your well-being, and one for sharing a record of your symptoms and well-being with a healthcare professional. What you see here is the symptoms that I've selected from the list of recognised long COVID symptoms. I haven't really got all of these symptoms, you'll be pleased to know. I have got a few, but not all of them. And what you see on the screen is just my most recent record. So you can see on the 24th of September, I said I had slight discomfort from chest tightness and I had distressing fatigue, for example. At any time, I can add to the list of symptoms. If I feel I haven't recorded all of them, I can go in and add more from the recognised list. I can also see for any symptom how the pattern of my symptoms has changed over time. Because I'm just doing this for a demo, I've got very made up data from just a couple of days, but a patient doing this for real would be recording, every few days or perhaps every week, and would quickly build up a picture of how their symptoms were changing over time. I can add a new score. So if I've decided that actually today my breathlessness is not too bad, and I want to record that. I'll just add slight discomfort, and you can see that new data point has been added. The patient can then choose to share each of these little records of their change in symptoms with a health and care professional, or it could just be with a family member or an informal carer. You just enter the email address of the person they want to send it to, their own name, and we ask them to enter date of birth. It's not mandatory, but we ask them to enter it to help if they are sending it to a healthcare professional. They can then marry it up with the patient's record. And they just click on share via email to send all of the graphs showing the change in their symptoms over time to their healthcare professional as a single PDF report. Conscious of time, so I won't go into much more detail there, but I will just briefly, since I'm on the phone, hopefully take the opportunity to show you one of the algorithmic tools, which is the FORAT, 4AT delirium screening tool, which we built specifically for support in the COVID pandemic. So this is a very, very simple risk assessment tool, but it's very strongly validated and very effective in identifying delirium, which of course is a key issue for patients with COVID, particularly older patients. The clinician simply answers these 4 questions from their assessment of the patient, click and calculate, they get a risk score and a result stating likelihood of delirium or cognitive impairment, and they can copy the result into an email or into the patient record. This is UKCA marked, so it fulfills all the requirements for clinical safety and clinical quality that are set by legislation and regulations. I'll stop sharing now and go back to share my PowerPoint slide again. I can. Okay. Hopefully I haven't lost too much time. So I've shown you the FORAT algorithmic tool. I'll come back to the Restore to one shortly in the presentation. A really key aspect of all of these decision support tools is the knowledge translation aspect. You might have seen I used that phrase when I was describing the platform. I'd just like to clarify it a bit further. It involves translating what's often very lengthy, hard to read PDF guidance. We've seen guidance that's hundreds of pages long into a decision-ready format. So it involves these knowledge translation skills of structuring, segmenting, summarizing, visualizing information, and implementing interactivity to make it usable and actionable. So a few examples. This is the Glasgow and Royal College COVID-19 mental health toolkit. Here, one section is all about prescribing of these mental health medications in COVID. You can see how well it's structured, just nicely broken down into all its sections and subsections. When you get to the lowest level, this is clozapine treatment, the user can then focus in on specific sections and choose to open and close those as they wish. So in this case, they've got the 2 sections, patient advice and maintaining full blood counts open. There's also full information about when the guidance was last reviewed and when it's due for next review and updating. This is an example of visualizing guidance as a visual pathway. This is the implementation flowchart for long COVID. You can see it embedded in the mobile app for long COVID for professionals here. The user can pinch and zoom so they can focus in on a particular node within the pathway, and they can click on this little information icon to open up a side panel with further evidence, links to patient information, etc. I've already shown you the mobile version of an interactive calculator, the delirium screening 4-at calculator. This is just the web interface for the same calculator. Impact. One of the great measures of impact has been the fact that these COVID tools have been embedded in wider tool sets that are in daily use by clinicians. So our overall calculator suite, the board-wide guidelines, our care home decision support toolkit, for example. So they've been seen as relevant to broader practice needs. You can see the data here on engaged sessions and usage. This is averaged across local and national tools. Most have continued to be continuously updated since first delivery, which is excellent and shows that continued ownership and engagement. And you can see very positive feedback, game-changing, one of the most important interventions in this situation, and incredibly useful. It's all really, really good to know that these tools were helpful. A learning experience for us was the work with Restore 2. This is an algorithm that supports early detection of acute illness or deterioration in care home patients. It was recommended by Scottish Government during COVID for use in care homes. We built the computerized algorithm. We got it UKCA marked, so it met all the clinical safety requirements, and it was intended for integration with the digital care home assessment tool. Sadly, this was not implemented. Two of the main reasons were that this project involved at least 6 partners, if not more, or many, many partners who all had a different perspective on the risks associated with the project. That made it very difficult to progress through to implementation. And due to COVID itself, there were wider delays in actually fully delivering the underlying care home assessment tool that we were to integrate with. So sadly, that one was not an immediate success story, but it did pave the way for a piece of work we've now embarked on, which is working with one of our health boards, Lothian, to develop a Restore 2 web and mobile toolkit as part of our wider care home decision support toolkit. This is much simpler because we just have one partner. We have the same understanding of risks and a clear understanding of our different roles and responsibilities. So all going well, this one will come to fruition. Key learning points: the value of our Once for Scotland technology and processes that we had ready to mobilise at pace. The value also of the knowledge translation skills. These developments were mainly, well, to a very large extent, were dependent not on technology skills, but those skills of translating and organising knowledge to be easy to use and actionable and decision ready at point of care. The fact we had a self-service tool set meant that boards could take ownership and deliver these tools locally after training and with their local governance in place. And also, as Pam already alluded to, the work with COVID has really served as a catalyst for wider use of the Right Decision Service and for embedding these COVID tools in wider clinical decision-making applications. So it was valuable throughout to remember that longer view and the longer term benefits that could come from these, sort of firefighting pieces of work. So thank you, and very happy to take questions, both myself and Pam. Thank you.
Thank you, Anne. It was a pleasure to listen to you. I have a question for you in Slido. How do you think these tools will work and will penetrate the healthcare systems of the future with an increasingly aging population?
So several of the tools that I've shown, like the delirium screening and Restore 2, are absolutely designed to support care of older people. They're very much targeted at care in care homes and for frail elderly people. Is the question asking more about challenges for older people using technology themselves?
Yes.
It's about yes. Well, it's been an interesting experience there. There's no sort of stereotypical generic older person that we can look to say, they always have this level of digital confidence or a different level. There are some older people that are absolutely au fait and comfortable and extremely knowledgeable about web and mobile devices. There are others definitely who are much less confident. I think there's two kind of approaches to that. One is providing the support that's needed to help older people to become more confident. And there are some key support roles. For example, we have roles called community link workers or community connectors who play a really important role in visiting people in their own homes or supporting them when they come to the general practice, and signposting and supporting them to use technology effectively. So I think there's benefit in building up those support roles to help older people use the technology. The other aspect is us making sure that we design this technology as much as we can with older people themselves so that it is as user-friendly as possible for them.
Okay, thank you again. Thank you, Anne, and thank you, Pam, for being here. Before the end of the event, we would like to take this opportunity to have a debate about all the work and all the experience we have had during these 6 years of Tittan project. Jose Maria, the project coordinator, it will be the moderator. So before I pass the floor to Jose Maria, I only would like to thank all the partners for the work during this year. So thanks, and Jose Maria, I give you the floor.
Thank you, Mercedes. Well, I will start before starting the debate.
Thank you, Mercedes. So before we start
the Tittan project, because, well, as Mercedes mentioned, it was 6 years of Tittan project. It's a lot of time with a lot of results and a lot of good practices is changed. Well, as we mentioned, this project started in 2016. We were 7 European regions, the regions that were represented today, plus in Lower Silesia in Poland and Almere in the Netherlands. And the project was divided into two phases. In the phase one, it was the learning exchange, where we were working more than 2.5 years, exchanging good practices. Where only to mention some figures, we exchanged between all partners 51 good practices into 3 thematic areas. And the phase two, we try to implement in each of the 7 regions an action plan of based on the good practices that we have learned. In 2021, it was the extension of the project, the last extension of the project that it was done by Interreg Europe in the framework of the Call 5, and 5 regions, the regions that we were here today. We continue this project, but with the aim to establish a knowledge exchange network promoting innovation in the field of the COVID-19 pandemic. Only in 1 year, we could exchange 36 good practices that we had identified in the 5 regions as a response of the COVID-19 pandemic. And we had 3 workshops and the final conference that we had today. These 3 workshops, they were this year. The first one was in March, organized by our colleagues from Scotland. The second workshop, it was on May, organized by our Saxony partners. And the last workshop, it was before the summer break, organized by our colleagues from Basque Country. And as we mentioned during the previous workshops, the idea is that at the end of this final conference, we will publish an assessment report that it will be a collection of the good practices and also with their contact details in order to continue exchanging good practices between the partners and between another regions that could be interested on this topic after the end of this Tittan project. And now we will make a short debate. I will invite to connect our colleagues, also Xavier, that he is here with me. Xavier, that he represents the BioF, the Basque Foundation for Health Research and Innovation, and also the other 3 partners, Paola Bello from the Regional Foundation for Biomedical Research, Olaf Müller from Healthy Saxony, and Cara Mackenzie from the Digital Health and Care Institute. Hello. Yeah, you can hear me? Great. Yes. Well, as you can see here in this screen, well, also Xavier is here. Now it's only me in this part of the screen. Well, we were the alma mater of the Tittan COVID project. It was a big challenge because, well, it was an extension and an extra call that the Interreg Secretariat offered us, and especially for us that we work in the health sector. It was for us a big compromise to continue 1 year of this project, at least exchanging the lessons learned during the COVID-19 pandemic. And I would start the first question that for all of you, that it's about the key learnings of the Tittan project that has provided to your region during these 6 years of the implementation of the Tittan project. If you think that what key learnings you could have, and also if there are any, that I'm sure that there are many lessons that you could learn during these 6 years, and if these good practices, or at least part or some of them, they were implemented in your regions. Maybe I start with you, Xavier, because you're here with me.
Perfect. So hi everyone, for all the rest partners from here from Galicia. Oh, this question is complex to reply because we have several experience after 6 years, and I'm fully sure that as all the rest partners, we also have dozens of experience that we could consider learnings. But if you let me to summarize my own experience in just only 2 categories, because indeed, we could talk hours of the small experience, but if we attend to these two categories, I could say that one of them, or the biggest, is the use of experience of others. So when someone, when a region or an organization is trying to solve a big challenge, and they try over and over again several solutions without finding a correct way to get success, it's quite important to know the solution already implemented for other institutions in order to select which one could be the suitable to implement in your organization or not. And let me share just only one experience. After 6 years, I could remember one special experience related with Scotland, with the partner of Scotland, because we had the chance to visit the DHA, and it was a marvelous way to deep in the to know in the Living It Up project and how they address a big problem trying to monitorize the chronic patients and the elders using a specific solution developed at home, ad hoc in their institution. Igor gave us previously some details about how to use this knowledge to improve our video conference or video consultations tools in the Basque Country, because indeed we use this experience to take some inspiration on how to guide our development of these tools in our region. And this experience was quite useful for our institution and of course for Osakidetza in order to select or at least reduce the number of options to try to implement in at home. And of course, just only trying to summarize all the experience, the second category that I would like to underline is the strengths. So after 6 years, after being focused in the last 2 years in the COVID-19 pandemic, I could say, or at least, I don't know if all the rest partners are agree with me, but I could say that all of them have a big knowledge of the strength of the other regions. And this is a quite useful and powerful tools for the future. Because, for example, if we could remember key learnings related with each region, I could say that the DHA is leading the innovation for home monitoring, of course, from Scotland. Saxony, they are also leading the development between the public and the private sector of tools implementing the healthcare system. Lombardy region also is they are breaking some barriers in order to implement and use this knowledge to the innovative emergency situation. Of course, Galicia, you are leading the leadership, I will say, in the public procurement innovation. So this knowledge is something that we are not only we are learning about all the regions, but also I'm fully sure that we will use this information for the future. And I'm sorry, because I tried to summarize all the experience of 6 years.
Well, we all know that we have many learnings. Maybe some of the partners that they are connected through. Yeah, maybe Olaf, you can tell us your experience during these 6 years of the Tittan project.
I mean, where should I start? Javier, we could talk hours. That's completely correct, and still wouldn't transport the whole magnitude of Tittan project. It is the culture of openly exchanging good practices, including what didn't work, is something that is very important and works really, really well. This always comes back to people. So it needed, and it had a fantastic group of open people that are willing to share and to listen while others are sharing. So this was a major experience for me. Very positive, very positive. Let's do that again.
Yeah. Maybe Paola, Cara, well, another question is about difficulties, and also I would like to connect also with the involvement of the authorities and your stakeholders. If it was a difficulty for you, maybe the involvement of authorities, because well, we know that sometimes we are, well, these projects, it's difficult that to have it as a strategic project. What was your experience in your cases?
Shall I go first?
Yeah, Paola. Yeah.
Okay. So first of all, before answering, I just would like to thank you very much for organizing this meeting today. It was really important to have these discussions at the end of the 6-year project. So with regard to the difficulties, I believe that what you mentioned is exactly the point. So you know that we, Tittan partners, obviously we represent our region, our ministries, but a lot, as it was said before, depends on people. So it is true that involving proper stakeholders and policymakers can be extremely difficult. It's not a lack of, let's say, political will, obviously, to take part in these kind of projects. But I mostly think it's a matter of time. So normally a policymaker has a very limited time. So sometimes they require, immediate result or immediate aspects to focus on. And the other problem, but I think that for that, the Tittan project really helped us to progress, is the importance of the networks. So as it happens in regions, but also in other institutions, policymakers and stakeholders are very much occupied working on the urgencies, on emergencies, on things that happen at the very same moment. So sometimes they don't have the time to think about how an issue could be tackled in a network and what would be the consequences in the future. So I don't think they don't consider networks such as the Tittan project important, but sometimes they don't see the proper value in time. So I believe that what we could do thanks to the Tittan project was to bring some knowledge to them, was to bring some added value to their work, explaining them what we try to do with the Tittan project and what we will be able to do in the future. So yes, we met some difficulties in the Tittan project, but obviously this experience helped us a lot to know better how to deal with our own policymakers and how to make sure they get more and more engaged in these kind of projects.
Yes, Cara?
Yeah, I would certainly agree with that. We were also able to use our DHI board to update kind of the policymakers and stakeholders, because a number of them are represented on the DHI board. So we were thankfully able to do that quarterly, which I think really helped us as well, kind of get the word out there about what we were doing with this project and what the best practices that were being presented were.
Yeah, and just one question, because well, we are a little running out of time. It's about the topic of today, about COVID-19. Do you think that your regions have been strengthened after this time of reflection and learning? Maybe I start with you, Xavier.
Yeah, absolutely, yes. Because after this exchange and this process of reflection, not only we have now a fine mapping of those research groups that lead the fight against the COVID-19 during the last 2 years, but also we put on the ground several solutions that at the very beginning of the COVID-19 pandemic was just an idea. And we have tested the pathways that can guide how to implement the solution in the real world. So in the end, or considering the whole experience, I could say that not only the professional, the health professional, not only the research development and innovative solutions implemented, but also the healthcare itself has a strong structure underpinning by the whole process. So definitely, yes.
The rest of the partners, maybe Olaf?
Well, as I said in the presentation, it was a good thing that we weren't first to have to respond to the situation, but second, I think the region in a whole as a whole learned something from the good practices of the other regions. Even though the systems are not that comparable, the health and care systems are not that comparable, but still there's always something true that can be translated and learned for the next situation, which is, as we probably agree, sure to come someday.
Yeah, Paola, Cara. Yes, Paola.
For what concerns our region, I believe, well, yes, in a sense, the crisis made the region stronger, but with stronger, I mean more flexible rather than more rigid. So I think the main lesson learned in this tragedy was that all systems, no matter how different they can be, no matter the structure, they need to learn to be flexible in order to adapt to the situations. And this can be done only, obviously, with a strong support of technology, which is thanks to the crisis, obviously, as developed at a much faster pace. But also flexibility is given by the structure. So I would say that the ability to create networks, to create hubs, to create a crisis unit really was, I would say, the main lesson learned. And in a sense, yes, this has improved our region.
Yes, Cara?
Yeah, I would say very much the same as the others have said, and particularly about the speed of how we were able to move forward with the technologies and innovations to deal with the pandemic. That improved greatly, and I think that will continue on, probably maybe not at the pace of during COVID, but I still think we have been able to move things much faster, and we'll be able to do so in the future.
Yes, well, in our case for Galicia, as our General Directorate for Public Health mentioned, the experience of Galicia in innovation helped us to fight against the COVID-19 pandemic. So, of course, projects such as Tittan project, that it was focused on innovation, especially for our region that we faced the problem of aging. It was very useful in order to develop innovative tools and innovative solutions that then helped us to fight against COVID-19. So, well, we are running out of time. I would like only just to thank you all because, well, to be here with us and also to be involved in the last extension of the Tittan project focused on COVID-19. Before ending the debate, I will give the floor to Mercedes because she will give you the results of the live polls that we had in slido.com. Mercedes?
Thanks for this enriching debate. As we have announced, we have created 2 polls in Slido at the beginning of the event, and we are looking forward to seeing the response from our audience. Thank you very much for voting and for participating in Slido. So now the first question was, do you think your region is now in a better position to deal with a new health crisis? In this case, in the first poll, the most voted option was A. Yes, we have improved the capacities of the system thanks to the implementation and good practice developed during the COVID. The second most voted was B. We have significantly improved our health system, but we need to continue to analyze and improve the measures implemented. And the last one was C. No, we are not prepared because our technical development have not sufficiently penetrated the system. And the second question was, what was the key element of your region's response during the COVID-19 pandemic. In this second poll, the majority of votes were for option A, the same as the first one. The second most popular option was B, improving data analysis and technology. And the last one was C, new models, resources, and organizations. So thanks for the participation.
Thank you very much, Mercedes. And thank you very much, all partners. And well, just the final words. Well, thank you, Xavier, and thank you, of course, Paola, Olaf, and Cara, to be part of this Tittan project, and also a special mention to our two partners that they were at the beginning from Almere and also from Lower Silesia, Witze and Antoni. And that's all from my side. I will now give the floor to our Galician Health Minister, Julio García Comesaña, who will make the closure of this event. Thank you very much.
Miembros de instituciones europeas, autoridades regionales, socios del proyecto, ponentes y demás entidades. Es para mí un placer intervenir en este evento en el marco del proyecto Tittan COVID-19. Quiero agradecerle la oportunidad que nos han dado, en este caso Interred Europa, gracias a la ejecución de este proyecto liderado por ACIS, de crear esta red de intercambio de conocimiento con otras regiones europeas para potenciar la innovación en el área de la salud. Para nuestro Gobierno, la innovación es un pilar fundamental. Así se contempla en la nueva RIS3 2021-2027 de Galicia. Su objetivo primero se enfoca en lograr un ecosistema más abierto e integrado, consolidando una oferta de I+D+I avanzada, integrada, organizada y alineada con la especialización capaz de responder a los retos de la digitalización y la sostenibilidad. Respecto a las buenas prácticas para la lucha contra la pandemia de la COVID-19 que se han estudiado durante este último periodo del proyecto Tittan, creo que Galicia ha sido referente dentro de España, entre otros motivos por nuestra respuesta inmediata a la pandemia y a nuestros buenos datos de vacunación, los mayores porcentajes de cobertura en todos los rangos de edad superiores a la media española.
Of coverage which are way above the average for Spain. But it's also clear that it's essential to have moments like this for reflection and analysis of all the experiences and highlighting all the learnings and analyzing all the stumbling blocks, assessing other measures adopted in other regions and making the most of the available synergies. This process will help us to be solvent in future crises. With regards to the region of Galicia, the government of Galicia on the 13th of March of 2020 declared a situation of emergency and enacted the territorial emergency plan for Galicia. From then on, the Coordination Center for Operation was established with the aim to guarantee the operational nature of the plan. The importance of proper decision-making supported by experts and innovative support solutions was key to our reaction during the pandemic. In this respect, I'd like to highlight the national program to support decision-making by the NHS of Scotland with several support solutions to decision-making for health professionals. I'd also like to highlight the best practices of our partners from Lombardy and Saxony that have proven how swift the systems have adapted. In the case of Lombardy, for all the initiatives implemented by the ASST Papa Giovanni 23 hospital in Bergamo during the acute phases of the pandemic. They were the first Europeans to face this crisis and helped other regions to have such an important reference at the time. In the case of Saxony, it's very significant and of great impact to see the great changes entailed by the clustering of regional hospitals which provides the health system with great resilience. In the case of Galicia, I'd like to highlight the task and success of pioneer actions that made Galicia a reference point. Among them, I'd like to remember, for instance, the drive-in COVID designed by the Hospital of Vigo that enabled to have much swifter COVID testing for all the participants in decision-making, going from 8 samples a day by team to more than 150 in one single day. We should not forget either the pooling scheme to group all of the tests by the Microbiology Center of Vigo that enacted in 2020, enabling to analyze in one single test the samples of several citizens and increasing the capacity for analysis and prevention. So we're going from one PCR in one single sample to have PCRs to 20 citizens with this group pooling system, and thus multiplying 20-fold the capacity and cutting the costs by 20. I'd like to also highlight the great development of applications that helped us be closer to the citizens at a time of total lockdown, such as the past COVID to receive news of trace and compets, and the impulse of Telea, the telemonitoring system of the Galician Health Service that fostered the follow-up of chronic patients at a distance and also COVID patients after their discharge. I'd like to also take the opportunity to speak about the integrated video consultation system by the Basque Health Department and also the Health Department of the Basque Country. I'd like to conclude my presentation by valuing the great effort and dedication and showing my thanks to the professionals in the Galician Health Service. All these were developed within the project of the Tittan project, the 3 workshops and this final workshop. This has been a great effort, enabling Galicia to be one of the Spanish communities with less incidence of COVID. So I conclude my presentation by thanking the work of those who have contributed to organizing this meeting with their efforts and dedication. Thank you very much to you all. Good afternoon.